Good evening. I'll tell you in a minute why I'm laughing at that. Okay, my name is John Mathias. I'm here from MPN Voice, and it's my pleasure to welcome you to our forum here this evening in Guy's Hospital. So for those of you who have been to one of these before, you'll see that it's a little bit different this time. The reason for that is that this is the first time we are actually streaming this event live on the internet. So as well as the getting on for 200 people that we have here in the room, there are approximately 300 people listening to this and watching it in the comfort of their own sitting rooms or wherever they happen to be sitting. So it's an experiment for us. I really hope it goes well because, as you probably know, the mission of MPN Voice is to reach out to as many patients with MPNs as we possibly can. And utilizing the internet to do that is a fantastic thing to do. And for that reason, I'd like to introduce Andrew Shaw, who's sitting at the front here. Andrew's actually, he's from an organization called Patient Power. It may be familiar to you because some of the videos that we have on the MPN Voice website are provided by Patient Power. And Andrew does a great job in interviewing doctors around the world, providing that video content for us. And Patient Power this evening are enabling us to do the live streaming of the event to our internet audience. So welcome, Andrew. Andrew will be taking questions from the internet and putting them to our speakers and our panel later on. So with that in mind, let's have a quick run through the agenda for this evening. So first up is Dipti Raudia. Some of you may know her. She's one of my doctors here at Guy's St Thomas's. She had the pleasure of sticking a needle into my hip several years ago. Not a particularly pleasant experience, but that was nothing to do with Dipti. So she'll be talking to us about how we measure symptoms. We have 3 patients who will be talking to us on a variety of different subjects. I'll allow them to introduce themselves as they come up to the front. John Lambert, consultant haematologist. John, are you here? I'm here. Great. That's what I like to see, all the speakers here in time. Will be talking to us again about symptoms. Then we'll have our interactive panel where we'll be joined by 2 ladies who run a fatigue clinic. And I know that that's a subject that a lot of you are concerned with. And then we move on and we've got Professor Mary Frances McMullen from Belfast talking about our Mosaic study, which I've told you, many of you, about in the past. She'll be giving us an update on the early results from that. Claire Harrison is also here, obviously. She'll be talking about the latest in research, and we will wrap up the formal proceedings with an update from Marilyn on our fundraising efforts. So that will be the kind of the formal bit. Then what we do is we break out into different discussion groups, either the kind of disease-specific discussion groups, so whether you have ET, PV, or MF, and we'll be telling you where to go for those breakout groups. And then we have a separate group which is more concerned with the effects on kind of family. So depending on your specific interest, we'll let you know which part of the floor to go to at that point. Okay? So it's my job to try and keep everything running to time. So with that in mind, I'm just going to... 2 more things. There are no fire alarms scheduled. So if the bells or sirens go, it's serious. There's the exit there and there. Go for the nearest one. Secondly, I've been asked if you don't mind, if you could switch off your mobile phones. There's a lot of sensitive electronic recording equipment. Obviously, some of you may want to leave them switched on, and that's fine. I'm not mandating this, but if you don't mind, if you could switch your phone off for the at least for the kind of the first bit of the evening, that would be great. Don't think there's any more housekeeping. Right, over to you, Dipti.
Is the mic on now? Great. Can you hear me at the back? Great, thank you. So I've had the privilege of talking about measuring symptoms in patients with MPN. And really, I'm going to talk through the journey of how we've developed symptom assessment forms and where we are with those symptoms, and some of the symptoms that patients have reported and how we've used those to develop symptom assessment forms. I have to say, with all this high-tech stuff, my symptoms at the moment are palpitations, nervousness, and not feeling quite ready to be on videos, but there we go, we'll carry on. So to start off with, this might be a bit of a familiar slide to you. You know, where you get to the doctors and the doctor says, well, your bloods are exactly where we want them. That's really good news and I'm really pleased. And you're sitting there thinking, oh, really? And that's not really quite how I feel. And we know that. We know what we see as doctors isn't necessarily how you feel, but how do we capture how you feel? We're looking at the research angle. I'm not going to talk about the numbers or the medication or the prognostic indications that we use, because you all know about the high risk, low risk. I'm going to specifically concentrate on the symptoms that we've discovered specifically affect the group of patients we look after and how we're trying to manage those as something that Dr. Lambert will take on. So the first time actually looking at a patient cohort where an MPN group was looked at was in 2007, and the person that's been pivotal in starting this journey for symptom assessment is Professor Ruben Meese, and you may have heard him in patient groups before, where he actually did an internet-based survey and used previous symptom assessments. There were loads of them, standard ones, and there was one called a brief fatigue inventory, and there's a specific symptom assessment form on effects of anemia. They're already out there, they're validated. He used those two in the internet survey, but he also asked the MPN patients, what symptoms do you have that really bother you? And the survey came back with 1,179 patients, and those were the symptoms that were reported in the percentages. So things that won't be a surprise to you: the itching, depends on whether you've got PV, the fevers, the night sweats, severe bone pain, quite severe bone pain or mild bone pain, and the splenic pain. And forgive the photos, the cartoons were better than some of the other ones, and undesired weight loss. But actually, the one that was overwhelming was this debilitating fatigue. 83% of patients reported that. So that was the first time specifically a survey was done looking at MPN patients and the patients' symptoms that they were reporting that we may not be capturing as clinicians. We've known, this is just the only technical slide I'm going to use, we've known for a long time that JAK-STAT and the signalling pathways that we know affect MPNs, and this was before we'd even discovered JAK2, that there are lots of signalling pathways that produce a whole load of mediators. There are cytokines, interleukins. That's how the body works. We also know it's these things that are produced that can cause symptoms and are probably involved in causing some of those symptoms in different degrees. And they affect patients in different degrees because it depends on how the patient or that individual reacts to those things that are being produced and how they're being manipulated. So everyone will have a completely different symptom profile, despite what we say is that MF should have this or ET should have this. It's not exactly one size fits all. So why measure them? Well, actually, one on the right is a school children asked about what makes up quality of life, and we use that all the time. The definition of quality of life is actually a holistic one: the physical, emotional, intellectual, and cultural satisfaction in everyone's life. So they asked a whole load of school children, I think they were 8-year-olds, and it was exactly what that diagram shows. It's about being happy at home, safe in your environment, being physically happy, having a good family. Transportation, I think that depends which part of the country you're in, and it affects you. Clean water, so that, you know, it's all these things that make up your quality of life. And what we were trying to ascertain is what is quality of life, but what is your quality of life as patients who have MPNs? This is a bit of a busy slide, but this slide talks about the journey of how the MPN assessments were developed. So if I start off with the very top publication, really, in 2007, after that internet survey was done, we had lots of patients with myelofibrosis. As you know, the myelofibrosis are the patients that have the most symptoms because of the way the disease progresses, the big spleen and their anemia and their fatigue. And there were quite a few trials being developed. So Professor Meese's group worked internationally to look at those particular patients to develop a myelofibrosis symptom assessment form so we could measure those. And he validated a symptom assessment form for MF in 2009. And that was used in some trials to help decide, are those drugs in trials making a difference to these patients? Because it's an objective measurement. You know, I can say to you, how are you feeling? And you can say tired, and you can go, okay, a little bit more than last time or a little bit less. That's really not being objective. 2 years later, in 2011, the group continued working internationally to then make that myelofibrosis symptom assessment form into an MPN symptom assessment form, which meant instead of using 15 or 16 criteria for fibrosis, they did a survey and took all the symptoms that affected patients with ET and PV and added them. So it became a 27 inventory form to capture all MPN patients. It was one form we could give to everybody. And the final one is really, the middle one is about how that was actually, that form was sent out to 402 patients, and that was internationally assessed to see if we could validate it and say, actually, it's not just the US patients, the UK patients, Italian patients, everyone has a breadth of the same symptoms. And this form captures that, because that's really quite important. And then the final one is the MPN TSS, or the MPN 10. And from all that data, it got quite difficult for patients in trials, because when you do trials, and how many of you are doing trials at the moment? You have loads of questionnaires to fill, so you have to have the validated EORTC 30 questions, a good ball pen for each session, and you have fatigue ones, and you have pain ones, and then the MPN ones, and you kind of got questionnaire fatigue. By the time you got to the last questionnaire, you're thinking, crikey, I'll just cross everything off or go down the middle. So the idea was to capture the 10 most pertinent symptoms that patients in MPNs experienced and put it in a condensed form. And that, at the moment, you will see is being called the MPN TSS, Total Symptom Score, or the MPN 10, because there are 10 most important questionnaires. And we'll talk about how that was developed and where that's used. So going back to that 402 patients when we went from just myelofibrotic patients to MPN SAF, it is a busy slide. So this is the whole questionnaire. And what you've got on that side is something called the brief fatigue inventory. It's one that's used for all cancer patients. So it was quite good to have a standard that everyone else has used to measure against. And then the other 27 are the ones that I was talking about that are all to do with the symptoms that we think are specific to MPN patients. And 0 meant they weren't there, 10 meant they were the worst ever, and a patient decides along the scale where they fit at that point in time or a week before that time, because we all know those symptoms vary as well. So it captures that in a snapshot. The important bit about this data, again, busy slide, was really it compared, on the right here, are the same questionnaires. There's one questionnaire that's used internationally called the EORTC QT30. It's 30 questions that's been used for cancer patients across the whole board, looking at all sorts of symptoms, including fatigue and anemia, and quality of life, and how it impacts people's quality of life. So those are the questions along the side. And the important bits of data were that patients who had metastatic cancer disease had a score here of 75. The lower the score is, the more effect that disease has on you. You compare it to the general population there, that's 89. So people also have symptoms. But it was the first time it was identified that myelofibrotic patients had a lower score, almost a comparable score to those patients that have metastatic cancer. So we were starting to put ourselves on a pegging to say, hang on, this is quite important. We found with that, the ET and PV patients usually are not as bad. And then there are other assessments here. I haven't pulled them all out. Global health and quality of life, which is what we're talking about. Patients with metastatic cancer gave a score of 56. Actually, the general population gave a score of 71 because it's encompassing a whole load of things, isn't it? But again, the MF patients were 59. And actually, there were slightly lower score patients in ET and PV. So again, it gave us a marker that although we see these as chronic conditions that are possibly indolent in some categories, they are comparable to other patients who have illnesses, and we ought to take this seriously. And again, fatigue, overwhelmingly important across the patch. Again, a busy slide, but again, this is quite important. When we started using these MPN TSS or the SAF surveys, we thought this is great, we can capture it. But what we were trying to say is that actually not every patient fits their category. So you could be a low-risk ET, but you could still feel dreadful. You get the aspirin, but it doesn't help your symptoms. You could be an intermediate risk, but you're still getting bone pain. And it's the high-risk patients that get the medication. How do we try and square that off? And how do we incorporate this data that we've got that affects the patient into our treatment pathway? Because the two don't match. So 1,470 patients were looked at using those forms. And these are wonderful heat maps. So I'm just going to orientate you. Forget those graphs. It just talks about the different symptoms. Concentrate on these. Those are ET patients, PV patients, and MF patients. Every little line is a patient saying they've either got the symptom or not got the symptom. Red means 8+, blue means less than 5, less than 2, and even some zeros. So as they're called heat maps, as you've got more symptoms, you get redder, and you've gone from blue to red. And it didn't matter, they didn't categorize the patients to their category that we do. They just said, who's the most symptomatic? And can we cut the patients up into groups to say the most symptomatic ones have the worst disease? And it wasn't that simple. And again, it told us this disease isn't that simple. We can't just correlate what we do medically. It's what's happening in that patient. It could be genetics. It could be how they're producing those mediators. It could be the drugs that are making a difference. But again, the themes were, up at the top there is fatigue. There's a little line that goes across the same point across all of those. That's fatigue. Almost every single patient had some degree of fatigue that was debilitating. The ET patients and the PV patients fitted into 5 different clusters. And the MF patients, as we know, are the more symptomatic because they do have the anemia and they do have the big spleen, so they were reporting more symptoms. And this was the only set of patients that fitted quite neatly into our clinical correlates. Still leaves the PV and ET patients that are chronic illnesses, that are not debilitating, but have a big symptom burden. And we need to know what to do with that. We need to know how to use that. And the idea also was we looked at quality of life, being happy at home, sexual activity, having problems with that. And as this was international, you won't be surprised that depending on the culture and the country, there were different reported activities or different reported difficulties. And the Italians were very vocal about having problems. The British and English were very quiet about discussing it. So you can't really translate everything, but this data told us there are cultural differences, there are gender differences, but the one thing is all the patients have some degree of symptoms, and it isn't one size fits all. We need to think about how we use this data in an individual and in our treatment plans that we have for the future. So this is the MPN 10. You all have a copy of this in your pack, and not now. When you have a break, it would be really useful because it would be nice to capture a snapshot of your patients here. If you circle the diagnosis that you have and just fill out the form. Leave it on the way out. You don't have to have your name. It would be nice to see what the snapshot is here. There are also forms that are outside for you to take home because this is what's been used for you to be aware of them. So where does that sit? So we've got this MPN TSS. What are we doing with it? Actually, there's been a flurry of activity and I haven't shown it here. Symptom assessment has become part and integral to trials. In fact, it's now what the FDA and what the what the drug authorizing and the new drug authorizing authorities will do is say, we want to know that this drug makes a difference in someone's quality of life. We know the drugs are important, we know the drugs are expensive, and you're using them in rarer and rarer patients. So for us to say this drug is going to be out for public use or be approved, it has to make a difference in quality of life. So they're integral to part of that. We've also used them in our clinical practice regularly because not every patient's on a trial. So it's quite nice to have your profile, and then even if we're changing our routine drugs to see if they're making a difference to your profile, or some of the fatigue clinics that we do, is it making a difference to your profile? So it becomes your measurement of your symptoms and is a bit more objective. Internationally, we're looking at how do we put them into these prognostic scores we're going, and that's going to take a little bit of time to work out. It's also been recognised in all the international trials and the international working group that it has to be integral to creating any scores and how drugs are done. We're also looking at these cytokine, and I apologise for the typo, I've spotted a second one, cytokine profiles that we talked about before, because the new targeted drugs, they manipulate those cytokine profiles. That's why they make some patients with MF feel better, a lot of them, because they're changing the cytokine profile. If we can identify those cytokines and profiles in different groups, we might be better aimed to targeting drugs. We might have a way of saying patients that aren't necessarily high risk but are very symptomatic may be eligible for these drugs. So we need to look at how we incorporate that. And actually, most importantly, it's part of what we should be doing as patient holistic care. It's not just about the drug and the numbers, it's about looking after a patient as a whole. So the idea would be, for patients that do find it's a struggle, regardless of what we do, we convert them or we help you along a journey with whatever therapy mode there is to try and decrease those symptoms. That's a combination of drugs and other things to make your quality of life a little bit better, because it's what we should be doing as clinicians and working with you doing that. I think that's my 10 minutes, isn't it?
Thank you very much, Dipti. Thank you. So I expect what Dipti said has triggered quite a lot of thinking on your part. Can I ask you to kind of hold your questions until we have the panel discussion, and you'll be able to put those questions as well as the ones that you have for the next sort of batch of speakers. If over the course of the evening you don't get your questions answered, and this is where I have to apologise to Maz because I didn't tell you all the things that are in your packs. One of the things in your packs is a question sheet. So if we don't get round to your question, what we would like to do is to give them to the relevant person after the event, and they will answer those questions and get back to you. Okay? So that's one of the other things in your pack. And the other thing is a feedback form on the event in general. So if by the end of the evening you could fill that in, it would be much appreciated. Okay, thanks, Dipti. Now, next up is one of the Louises. Let me get this right. So it's Louise Simpson. So if you'd like to come up to the front, Louise. I think your slides should follow on straight away. There we go. That's you. Great. Thank you very much.
Okay. Hello and good evening. I'm very grateful. I'm very grateful to have been asked. I'm very grateful to have been asked to talk tonight and to share with you some of my journey so far. In order to keep to the allocated 5 minutes, I promise I'll make it brief. My name is Louise, I'm 41 years old and I have PV. I have both elevated red blood cells and platelets. However, I am very fortunate that my only treatment currently is 75 milligrams of aspirin daily, along with regular or not so regular vivisections. I have had many symptoms over the years, which of what I won't bore you with, as I'm sure many of you have or still have experiencing a lot of the same symptoms. But the most deliberating back then was migraines. They affected my work, my social life, and if I wasn't having one, I was paranoid that I was going to get one, or I had what I call the migraine hangover. So I was going in a vicious circle. I felt trapped in a controlling relationship. I was desperately unhappy, frustrated, and no one took me seriously, and I felt like I was a hypochondriac. I was finally diagnosed in May 2009 after a lovely young man, a new GP, finally took notice of my elevated blood counts and uttered the words polycythemia. Obviously, I asked him to spell it. I went back to work and I Googled it, and thank goodness for Google because I honestly didn't have a clue. Anyway, he referred me to a local haematologist, and after the usual baseline tests, I was JAK2 positive. Obviously, I was in huge shock at the diagnosis, but also, along with that, came huge relief too. I just finally knew what I'd thought all along, that something wasn't right and I wasn't well. I have learned a lot about myself, my body, and how to manage this disorder. I know each one of us is unique, and I'm not for one moment saying that what works for one person would work for another. However, for me personally, eating well, most of the time, making sure I eat organic where possible, having an alkaline diet as much as possible, I couldn't give up alcohol completely, using good nutrition, limiting stress, and basically reducing my toxic load and regularly exercising have played a huge part in my transformation. I also invest in my health. I see a PT now once a week, I run as much as I can, and I see a fantastic nutritionist who keeps me on track. I'm actually a pescatarian or demi-veggie, and I'm gluten intolerant. Some people might say it's expensive, but I always turn around and say, what price on health? I would have paid anything to be migraine-free back then, and I'm sure you'll all agree that we would pay anything for a cure. I have also learned that having a positive attitude, and living a life of gratitude, hence the slide, creates more happiness, good health, and success. When I focus on the positives, I attract only more positive things. But when I forget, I actually focus on the negatives, and guess what? More negatives appear. Sometimes, and it's not easy, but when you're grateful for even the smallest things, life is so much easier and better. Last year, I was challenged further when I was diagnosed with bladder cancer. I had an operation to move the tumours in early November. I was further shocked to find out in December, confirmed by an early scan, to be 7 weeks pregnant. Unfortunately, on the 6th of January this year, at 11 weeks, I lost the baby. My tattoo on my wrist is a symbol for my little star. I'll spare you the other tattoos for now. I am a firm believer in things happen for a reason, good and bad, but it is how we react or deal with these things that really is important. I have done a lot of personal development through the business I joined in 2013, and I have been privileged to have met and trained by some amazing, inspirational people, all with their own story. I truly believe that this has helped me through the most difficult of days, weeks, and months, and has shaped the person I am today. I believe I am work in progress, and one of my favourite sayings is, we should always grow through life, not just go through life. That leads me on to the mind. The mind is a powerful tool which, used correctly, can create amazing things, but used incorrectly can have devastating effects. I can highly recommend many books, but the one has motivated me to get back out there and running after everything last year was The Slight Edge. I haven't got time to explain in huge detail, but I'm happy to talk about it afterwards. But that was really what got me out and back off my derriere, I guess. I set a goal to run a 5K, not a huge distance for some people who run, but as I hadn't run for months, it actually was quite a challenge. So with 5 friends, on a Saturday morning of my birthday weekend in March, we ran Bushy Park 5K, raising over £500 for MPN Voice. As Claire Harrison and MPN Voice have always given me so much, I wanted to give something back. I've stopped making excuses, and although I know my limitations, there is another saying, I love quotes, the only limits in your life are those that you set yourself. I have huge gratitude for my life, and through my businesses I help others, and I love being able to do that. I want to inspire people to do more, be more, and live a life without limitation. I stand here today a very different person to that girl 6 years ago. I have met some wonderful people throughout my journey so far, and I have great memories of abseiling down Guy's Tower and meeting the wonderful Ange Watson, who's talking soon, 5 years ago. And although we've only actually met now for the second time, we are really great friends. I also then went on to throw myself. I was actually pushed out of a plane at 13,000 feet, skydiving 3 years ago, again raising much needed funds for MPN Voice. I'll be looking for my next challenge after I finish a 10K in September. And I'd just like to close by saying I owe so much to Claire Harrison and the team at Guy's Hospital. And I know when I need it most, they are always, always here to support me. So it's only fair that I do what I can to support the charity and others. So thank you, and thank you all for listening.
Louise said something then about giving back. Okay, so as well as all her fantastic fundraising activities, standing up here in front of you guys and in front of our internet audience, that's a fantastic contribution to patient support as well. Thank you very, very much for your story, Louise. Okay, so now we have another Louise to come and talk to us. This is Louise Broughton. Is that the pronunciation right? Right.
I'm the old girl on the block.
Okay, so over to you, Louise. Here's the mic.
Okay, mics, papers, bits of... Hang on, I've got to get this right. Ah, there she is, the old bird sitting on top of a mountain. Hello, everybody. My name's Louise Broughton. I'm 61 and I live in Windermere in Cumbria, and I am currently a patient at the Christie Hospital in Manchester under a fantastic haematologist called Tim Somervale. I was diagnosed with PV 6 years ago with a hematocrit of almost 70 and all the usual symptoms ranging from headache to fatigue to bone pain, and we all know about everything, don't we? The worst thing for me was the aquagenic pruritus, the itching, which, for those ladies in the audience, you chaps won't understand this, but it's like having, and I look at the consultants as she's speaking, it's like having thrush under your skin, a blowtorch on the outside, and about 1,000 insects biting you at the same time. It's far more than an itch, folks. It's very, very unpleasant and can be quite debilitating at times. My original haematologist was a super chap, but he didn't really give me very much information. And after my first consultancy, he told me that a change in diet and lifestyle probably wouldn't help very much. And he sent me packing with a very large bag of something called hydroxycarbamide, which I thought, goodness me, so Google that. That was a massive mistake. Anyway, and the words, remember, Mrs. Broughton, you'll be at severe risk of having a stroke until we can lower your hematocrit. So I spent the next 12 months lying in bed at midnight, holding my arms up in the air and thinking, well, I haven't had a stroke yet, and I can still recite nursery rhymes, I must be okay. So there was I. My husband thought I'd lost the plot, obviously. Anyway, after the first consultation, I drove home feeling very, very sorry for myself, in a total fog as to what exactly was going on, because I hadn't actually discovered MPD Voice at this time. And I even, to my shame, although no, why should we be ashamed of shedding a tear or two, which is unlike me, of self-pity. And I was pretty fed up, I think, as everybody was, really concerned, actually frightened. I didn't know what the future held for me. And I was jolly tired. Even going up the stairs left me feeling like a wet lettuce, and showering almost reduced me to tears every time. After one particular episode of aquagenic pruritus, I thought, you're on your own here, girl. Buck up and do something to help yourself. First of all, I thought, right, from now on, it's going to be cup 3/4 full. No more feeling sorry for yourself. So I totted up my blessings. I think that's something we don't actually all do enough. Instead of sort of looking on the dark side, we never think, how lucky am I actually to even be here? So I've got a fantastic husband and 2 beautiful daughters, one of who is sitting over there and did these lovely slides for me. I've got a fabulous 93-year-old mother who, despite having vascular dementia, she lives in part of the house with us, and she makes me laugh every day. So that's my mother. I have a nice warm home and plenty of food on the table. Bits of me aren't swelling up or dropping off or needing replacing. I still look reasonably normal, so she moving on quickly. And I can still put one leg in front of another. We live in one of the most civilized countries in the world. We're not being shot at. We don't have typhoons or volcanoes. And we have, I think we all have to admit, one of the best health services in the world as well, despite the fact that everybody criticises it. I think we're very lucky. So, what's not to feel happy about? Rule 1 for me, and as Louise says, this all works for me. It may not work for you, but it's really worth giving it a go. Positive thinking and a change in lifestyle can really, really turn your life around. It certainly turned mine around. And then I started to walk every day, mainly because I've got a little dog and she was sitting there looking at me. And I found that walking briskly for an hour, longer if I could, made me feel much better. The pruritus had significantly lessened by the time I got home. And I know that it isn't easy when all you want to do is sit in a chair and watch the telly or read a book or listen to the radio and you're feeling shattered. It's really hard to drag yourself out. But that's what I do, because if I feel grotty or tired, that's the time I know that I need to get out and get some exercise. And then I noticed one day that the more water I drank, the better I felt. Pruritus again was helped, fatigue was helped, and so I gradually upped my Liga half litre intake a day to 2 to 3 litres every 24 hours, which probably sounds an incredible amount of water, but actually over 24 hours it isn't really that much. So, rule number 2, walk lots. And drink lots of water, not seawater, obviously, but that's the only slide we could find. I had my walking poles and some water on it. So that's rule number 2. And then, really, the itch was still affecting me. This ghastly pruritus was still affecting me. And so I thought, right, I'm going to note down what makes this itch itchy. And I'm not going to do any of it anymore. And first off the list was bathing, showering, and swimming. Wait for it. I haven't had a bath or a shower or been swimming for 5 years. I can see you all thinking, my God, I'm glad she's down there and we're up here. But in actual fact, it's fine. I have a bidet for feet and derriere. I wash my underarms in a basin. I wash my hair over the bath. And the rest I manage with baby wipes and flannels. And I'm sure those two delightful young people I'm sitting next to haven't really been put out too much, have you, by the waft coming along? So that's really not, for me, as not pruritus on the head. But along with that, I stopped wearing tights and synthetic clothing. I avoid air conditioning and trying on clothes in changing rooms. I buy all my clothes online and try them at home as and when. I cut out sugar, I cut out caffeine, and I stopped drinking alcohol, which was difficult, really difficult, as you can imagine. But anyway, there we go. So, rule number 3 is work out what makes you feel better and do it, no matter what others think. At the beginning of 2010, I read an article about a cancer centre in Bristol who promote an organic diet to aid the health of its patients. Now, if you're anything like me, you'll be thinking, organic food, what a load of blooming rubbish, expensive rubbish that is. Well, I thought, I don't have any tumours, but it can't do me any harm. So out of the pantry went the ready-made, the processed, the tinned, the packeted, and any tubes of gloop, tomato paste and ketchup. Out went all the stuff containing preservatives, additives, chemicals and pesticides. I thought, if I'm loading my body with chemicals in the form of drugs and medication, it might be a jolly good idea to cut out chemicals in the form of food and drink. And we do actually take in an enormous amount of chemicals in the form of our food. In came bucket loads of organic fruit and veg, and into the freezer went stacks of fresh non-farm fish from the fishmonger and organic meat. I changed refined flours, sugar, white rice and pasta and salt, and I changed everything for organic. Mr. Grumpy wasn't happy. He saw his supplies dwindling and the household budget rising rapidly. We bought a bread maker, which I guess I had to do something to keep the old boy sweet as he watched me ditch the chocky bickies and the crisps, and made him eat lots more fruit and veg. Is all this expensive? As Louise said, yes, of course it's expensive, or more expensive than probably the diet you have at the moment. Does food preparation take longer? Yes, I spend an enormous amount of time in the kitchen. Is it hard to completely change the way you eat? Yes, it is. I won't wrap it up. It really is. But I'm 3 years down the line now, and I wouldn't go back to eating the way I did for anything. So, if you really can't or don't want to afford organic produce, it's better to eat non-organic than no healthy produce at all. So up the fruit and veg, but if you don't want to buy organic, then, well, eat otherwise. But do try Googling, actually, the 12 dirtiest fruit and veg. You'll be surprised. And those are the ones that receive the most chemical treatment. And just buy those in organic form. I would urge you, though, to buy non-farmed fish and organic chicken. After all, if you can buy 3 chickens for a tenner, where on earth are they coming from and what are they full of? I don't eat dairy produce anymore, by the way, and I do buy organic for my husband and my mother. And probably 12 months into this change of lifestyle, I started to sleep better. The fatigue completely disappeared. Pruritus went. I mean, the disappearance of fatigue could be to do with the fact that I lost almost 2 stone. What a little porky I must have been before, they're all thinking. Anyway, but I like to think that it's mainly related to my positive mindset and the quality of food and drink that I'm putting into my body and to a complete change in lifestyle. Before I finish, I'd just like to quote a few things written by a French physician practicing in the US, a guy called Dr. David Servan-Schreiber. Now, I only read about him about 12 months ago, thanks to a lovely lady called Violet, who's in the audience somewhere, who recommended his book to me. This guy was diagnosed with a malignant brain tumour at the age of 31. And he had 2 operations, lots of treatment, but it kept coming back. And he decided that he would try and do something for himself in the form of what Louise and I have been talking about, mind and body. And this is what he wrote, which I thought was very telling. There's a little bit before that, by the way, but I thought that was the most precise. Most people, including cancer patients, live with the understanding that there is little they can do to prevent cancer, to make themselves feel better if they have cancer, or to make their lives longer. This is a fundamentally false belief. People can greatly reduce their chances of dying from cancer by changing their lifestyle and their environment. These changes, even if they're small, strengthen the immune system. Healthy living doesn't just protect you from cancer, even if you already have it. It gives you more energy, more stamina, and a better memory. If patients are better informed about their disease, if they can look after their mind and their body, and if they're given what they need to improve their health, then they can mobilize the body's vital functions to fight whatever cancer they might have. They live better and for longer. And I believe that he was absolutely right. David Servan-Schreiber died at the age of 51, almost 20 years after his initial diagnosis, when he was told he probably wouldn't live for more than 5 years. Thanks very much.
Thank you, Louise. That was a marvellous talk. Extremely professional, I think, I would say. You must do this very often, I think. Okay, so our last patient speaker is Ange Watson. So if you'd like to come to the front. You don't have a slide, but we've got this on the, just to remind everybody. Okay, over to you.
I did rather large print because with PV you get blurred vision.
Oh, sorry.
Is it working? Oh, good. Okay. Hello, everybody. Good evening. And I'm grateful for the opportunity to talk to you all this evening. You'll be happy to know that my name is not Louise. I'm Ange, and I will talk a lot less than they did. I'm 48, and I know what you're thinking. How do I look so youthful with such an athletic physique and keep my sense of humour? Well, actually, I'll get back to you on those points, but my story begins age 35, feeling continually unwell. I was just simply exhausted all of the time. I was visiting my GP so much, they had a name on my chair in the surgery, and at one point I was actually called a hypochondriac by my GP, which was rather sad, I thought. Unfortunately, when I turned 40, my GP sadly died doing the London to Brighton bike ride for charity at the age of 35, which I thought was very sad. But then he was replaced by a fresh-faced newbie called Dr. Joe McGilligan from Red Hill Surgery in Surrey. And quite frankly, that man saved my life. Around the same time, or thereabouts, an auntie of mine, my mother's sister, was diagnosed with a disorder that none of us could pronounce. And just by some sheer coincidence, I resurrected that memory from my memory banks and mentioned this to my GP. So he then looked through my medical records and noticed that my red blood cell count was consistently high. And although he felt that was probably normal for me, he then referred me to see a haematologist. I haven't got dementia, I promise. So he referred me to a haematologist who then, which led to my diagnosis of PV being JAK2 positive, which coincidentally was the same disorder as my auntie. We subsequently found out that we also had an uncle in the family with PV who sadly went on to develop leukemia and passed away. And my auntie has also developed the leukemia and at the moment is undergoing some treatment. And we're hoping for a very positive outcome for that. So my thoughts go to her this evening. Anyway, my cheeky little GP told me about a support group called MPN Voice, or at the time, NPD Voice. So I contacted them, And quite frankly, I've never looked back. And this group has actually been the key to my survival. Being able to talk to others who understood my diagnosis and talking without fear, and also being sort of comforted and to know that there's going to be a positive outcome for my future and what my future held for me. And this is something I will always be grateful for. Actually, my first buddy was in the audience tonight, and her name's Nona. Where are you? Thank you very much. She was the very first person I spoke to 8 years ago when I was diagnosed. So the first thing I did, rather sneakily, was get a referral to see Professor Claire Harrison here at Guy's, who then put me on my treatment plan. So I actually consider myself to be very, very lucky to have been diagnosed so young. I've got no lasting physical complaints apart from the severe fatigue that everyone has talked about this evening. So how do I cope with that fatigue? Well, quite frankly, like both the Louises have touched on, it's about nutrition and exercise. Nothing like stealing my thunder though, guys. So that's cut off about 5 minutes from my speech tonight. Anyway, what I do believe in as well, that you also need to listen to your body. So if you're saying, I want to go home and sleep for 14 hours, do it. Go home and sleep for 14 hours because that's what your body's telling you to do. It's worked for me, although now these days with the nutrition and the exercise plan and the water, lack of alcohol, lack of chocolate, I find now that I am sleeping a lot better. And I do have a little bit more energy, which is really good. I do work full time, which has in the past become a bit of a problem. I found that in my previous role, when I worked in London for an investment consultancy, that I was continually being disciplined for my performance issues, for lateness, because I couldn't drag myself out of bed. So I did keep my diagnosis a secret for a very long time, for fear of being judged in the workplace. Luckily now, a lot of employers know, actually, that they can't discriminate, and you'll find largely a lot of organisations these days are very supportive of people that have got chronic illnesses. I'm lucky now, unfortunately, to be in an organisation where they believe in work-life balance. So in the long run, I did find it useful to talk to the right people. And again, that started with this support group. But I did find sometimes you needed to be a bit selective with your audience because not everybody's interested, not everybody understands, and quite frankly, most people wouldn't even show an interest. So I believe it's important to talk to your medical experts first and foremost. The support group as well comes into that. You know, we've made a lot of good friends here, Louise and I, and now the other Louise. And I do believe it's important to listen to your clinicians. Occasionally, we might get misdiagnosed with things. Therefore, I would always advise a second opinion if you're not happy. But 9 times out of 10, the condition is a bit more well known. 8 years ago, my GP didn't know anything about it, and I ended up having to get a new GP to actually get to the diagnosis. But I do say, and slightly disagree with some beliefs, but I always say, don't Google anything. Quite frankly, a lot of the statistics and information online is out of date. I would say the first place to start, especially with this condition, is to come right back to this group. A lot of information is there. You only need to really speak to the guys here who specialise in the area. And I believe that our medical experts are second to none. Some of us have had delays in the diagnosis, but once we're on the right track, I can say with confidence that you should always listen to your specialist. And the biggest step of all, with any chronic illness, and that goes across the board, is to stay positive, and that is an absolute must. And we've seen evidence of that with both the Louises this evening. I've actually got a natural tendency to be a bit negative, and I think that's because I'm a little bit mistrusting sometimes, but over the years I have grown to believe in myself a bit more as well. And I've had a lot of support from family and friends, and also, you know, the support group as well. And interestingly, since my diagnosis, and the family members that have also been diagnosed, it's raised a little bit of interest in the medical industry. And we sent away DNA samples to Professor Skoda in Switzerland, who identified that there's a slight anomaly in one of our genes. So PV is probably prevalent in my family. And statistically, it's going to probably show a lot more than the average family, because my grandparents had 11 children. And I'm one of 48 grandchildren, I believe, at this count, but I actually do know them all as well. Anyway, just when I thought PV was bad enough, 2 years ago, I was diagnosed with a very common disorder called hemochromatosis, which means I've got an overload of iron in my blood, which that corrodes all your organs and causes bone pain. So a lot of my symptoms were very similar. And it was actually found out quite by accident when my consultant at Gloucester Royal Hospital looked at my results. So, you know, I just can't get enough of being prodded and poked each month. Love a bit of venesection. Shoving that bit of guttering in your arm every month is great. But that's what we cope with. Anyway, so going back to my original question, how do I keep my youthful looks, my natural athletic physique, and my sense of humour? Well, that's really easy. That's down to the hard work and dedication and the sheer brilliance of the likes of Professor Claire Harrison and her team, and all of the people that I've met here over the last 8 years. So thank you very much. Thank you.
Thank you, Ange. I think you'll agree that those 3 patient stories, you know, they're inspiring, they're useful, they're informative, and more than anything else, I think we can all, you know, kind of empathise with the kind of the stories that we've heard. The next thing that we're going to do before we have our panel discussion is I'd like to invite up to the front Dr. John Lambert, and he's from UCH here in London, and he's going to talk to us a bit more about how we manage symptoms. So over to you, John.
All right, good evening. Can you hear me at the back with the microphone on? Yes, jolly good. Right. So I've got 10 minutes to try to address all of the different symptoms which have been raised in the past half hour. When I tried to write my talk about a week ago, I was getting quite depressed because these are actually difficult symptoms. They're often quite debilitating. And we know that the kind of symptoms that we're talking about are actually symptoms that we as doctors are actually very poor, A, at recognising, and B, at actually treating. So I'm actually very glad to have followed those 3 last speakers, actually, because they've actually covered a lot of the stuff that I was planning to talk about. And actually, well, they've done a lot of my work for me, so thank you. Right, let me just bring up my talk, if I can. There we go. So this is just really a slide, I don't know how well it projects, to sort of recap some of the symptoms which Deepti and also the 3 patients have talked about. And 2 things to take away from that. First of all, that fatigue is clearly the most prevalent, the most debilitating symptom, and that, I think, reflects what we see in clinic, that fatigue is really a big problem. Yes, you've got all the other symptoms which I'll try to run through. I won't have time to cover all of them. The things like sweats, pruritus, fevers, weight loss, all of the more generalized symptoms, but certainly fatigue is the prime symptom. The second thing I just want to take out of this is if you look at there's 4 columns, but if you look at the 3, the green, which is myelofibrosis, red, which is polycythemia, and blue, which is essential thrombocythemia, you can see that, yes, although the symptoms tend to be more prevalent in myelofibrosis, actually in ET and PV, which we tend to think of, certainly as physicians, as like the milder myeloproliferative diseases, actually the symptoms are almost as prevalent, in some cases more prevalent, in ET and PV as they are in myelofibrosis. So I think for me, one of the things which I've learned since sort of specialising in this condition over the last 7-8 years is that actually, yes, myelofibrosis is what we tend to think of as being, if like, the most severe form, but even ET and PV do have quite a significant symptom burden, which is often not well recognised, both, certainly amongst the medical sort of profession. So the first symptom I want to focus on is fatigue. We're not talking here, obviously, about typical, tiredness, the kind of tiredness you have if you haven't had a good night's sleep. This is debilitating fatigue, things which interfere with daily life. And crucially, it's a kind of tiredness you get which isn't relieved by a good night's sleep or a couple of nights' sleep. Patients will tell me that they go to bed at 9:30, 8:30 sometimes. They sleep for 10 hours, but they don't feel refreshed in the morning. And that's quite different from the kind of tiredness you might expect that we all get from time to time leading busy lives. So this is what I'm talking about. And the question is, does anything help? You've actually heard a lot of what the best solutions are, which is diet, exercise, etc. There's actually relatively little evidence in myeloproliferative disorders looking at the role of exercise. But with my other hat, which is a lymphoma doctor, there's a lot more evidence in in hematological malignancies such as lymphoma for the role of exercise in fatigue related either to hematological cancers or to the treatment, the chemotherapy which we give for that. So I'm just going to present really one sort of snapshot study showing that actually a graded exercise program is clearly effective for most but not all patients. So this is a busy slide. This is 120 odd patients who have been treated for lymphoma, and it's looking at a number of different outcomes, but essentially they were randomized into two groups. Half were given a graded exercise program, and I'll talk about what graded exercise means in a moment, and half received no specific intervention. And if we look just at the outcome we're interested in here, which is fatigue, you can see if you look at their baseline fatigue measures, they were fairly similar, but after 3 months worth of exercise, you can see that those who'd had the exercise, which is the bottom row, had done significantly better than those who hadn't received any exercise at all. And that, if you're interested in the statistics, both on univariate and multivariate analysis, so that's comparing for all the other potential factors that might have affected that, is significant. So that's clear evidence showing that an exercise program can improve fatigue, and that tells us that what we shouldn't be doing, or what our patients shouldn't be doing, is just they're trying to rest more and relax. Actually should be getting out and trying to do some form of exercise. Now, what kind of exercise? Most recommendations would be that it's a combination of aerobic and muscle building exercise, and it's done on an incrementally increasing basis. So mild exercise doesn't do any good. People have looked at this. So if you're not getting your pulse up, if you're not feeling a bit tired by the end of it, that's probably not enough. Equally, exercise which is going to make you feel absolutely shattered the following day is too much and is counterproductive. So it's trying to get that sweet spot of enough exercise to make you feel tired at the time, but not leave you feeling exhausted the following day. And in ballpark figures, what people suggest is you try to get your pulse rate up, and your maximum pulse rate depends on your age. But if you work out what that is, you're trying to get it up to somewhere between about 50 and 80% roughly of your maximum pulse rate for a variable period of time. That might initially only be 5 or 10 minutes a day. That might be a brisk walk. But it's a matter of, on a weekly basis, trying to increase that. So instead of doing 10 minutes, you're doing 15 minutes and 20 minutes, till you're reaching the point where, as I say, you're feeling tired but not too tired. And that, several of my patients have tried and works in some people, but not in everybody. It's a matter of trying it, and all of these suggestions I'm going to be making over the next 5 minutes really a matter of they work for some people, but not for everybody. So it's a matter of trying it and see what works for you. Other approaches to lethargy, which I think we'll be talking about as well in the panel discussion. Diet, clearly critical. A healthy diet, and whatever you define as a healthy diet, I mean, there's clearly guidelines from the government of what's a healthy diet, but a lot of people will go beyond that, as we've heard today. Some people sometimes ask about stimulant drugs. I have heard of people getting prescribed things like Ritalin. Sometimes people rely on caffeine. I certainly wouldn't recommend either of those. I think the idea that you're using a stimulant to try to feel better is a short-term measure. You might feel better initially, but not in the longer term. I would always recommend against that. And with a little bit of data towards the end of my talk, talking about ruxolitinib as a JAK inhibitor, which does certainly provide some relief from lethargy. So that is one approach, particularly in myelofibrosis, although there may be some benefit as well in the other myeloproliferative disorders. I think the key thing about lethargy is having that conversation with your physician and trying to come to some kind of solution as to what's going to suit you best. Right, the second main symptom, which I think people find most debilitating, is pruritus, as we've already heard today. It is absolutely debilitating in some people. And whilst classically it says aquagenic pruritus, so caused by maybe hot water, or certainly water, some patients have got other stimuli, dry air. When they're exhausted, it's not just necessarily water, but as my next slide shows, the key thing is obviously is to try to avoid whatever the stimulus is. And sometimes people find that if they use a towel to dry themselves, that makes it worse. So either allowing themselves to air dry or to pat themselves can sometimes be beneficial. But again, different people have different experiences. There's a whole long list of other things which may be of use. And in medicine, the general rule is that if there's lots of potential treatments for something, probably none of them work very well. So just to reinforce that point, this is a study that was published in the United States a couple of years ago. You probably can't read that very well, so I've summarized it here. These are a variety of different treatments for pruritus. And you can see that the most common three, which is antihistamines, antidepressants, such as, we don't tend to use very much over here, but sometimes things like Prozac they do use over there, and topical steroid creams, which are the ones used in the most patients, only had a response rate of about a third. The lesser used things, which was JAK inhibitor, most commonly ruxolitinib, as well as thalidomide and pain relievers, and this was a variety of things, non-steroidals, some opiates, actually had a better response rate, but in a very small number of patients, so it's difficult to draw firm conclusions. But again, the message is there's no one treatment that works for everybody. It's a matter of trying different things, having that discussion, and trying to personalize it for you. Right. So, other symptoms. Headaches. We've already heard migraine-type symptoms. Sometimes patients get more non-migrainous headaches, but again, can be very severe. And the other symptom there with the red hand, some of you may suffer from this, is erythromelalgia, which is when you get burning, redness of typically the palms of the hands and the soles of the feet. Again, can be very severe. These are all related to problems with the microvascular, so the small blood vessel circulation. And so the standard treatment for that is aspirin, which most patients will be on anyway, to reduce the risk of blood clots, strokes, heart attacks, etc. But also often these are symptoms which will improve with better blood count control. So the other symptoms often don't, but these can do. And in fact, I've got a number of patients who will know if their platelet count or their hematocrit is above the target, because they'll come and say, John, I've got my headaches are coming back, and they know that their counts are going up even before we've taken any blood from them. Clearly stopping smoking and sort of standard healthy lifestyle messages are also important here. Right, I think I'm running out of time. So, symptoms due to splenomegaly. So you can see here just from this cross-sectional image that your enlarged spleen can certainly cause pain, partly by compressing the rest of the abdominal content, and partly if it outgrows its blood supply, you can get what's called splenic infarction, and that can cause very severe pain. The other symptom you can get from splenomegaly is that you can probably just about see the stomach. It's compressing the stomach, which means if you try to have a big meal, the stomach can't expand, and therefore you feel full very quickly. And that's early satiety. Now, the traditional approaches would have been either with drugs like busulfan, hydroxycarbamide. They're not very good at shrinking the spleen. The comfort studies have shown that the JAK inhibitors are much better, and they are the modern approach, really, certainly in myelofibrosis, to treating people who've got enlarged spleens causing symptoms. Splenic radiotherapy is less common now that we've got the JAK inhibitors, but certainly it can be very effective. The downsides, it can cause low blood counts, and sometimes these low blood counts can last a very long time. But if we select the patient correctly, then we can actually find that it can be very effective, often with tiny little doses of radiotherapy, given once a week, once or twice a week, until people get relief. You often don't need to shrink the spleen very much to get a symptomatic benefit. And again, in the old days, we used to do more splenectomies. These days, we do relatively few. This is just one slide from the COMFORT 2 study showing that if you've got the patients who are on the ruxolitinib arm, very quickly you get a 30% shrinkage in the spleen initially, and gradually that goes down to about 40%. And as I said before, you don't need a massive degree of splenic shrinkage. 30–40% is often accompanied by a marked improvement in symptoms. Right. So this is a little bit of a sort of a hodgepodge of symptoms, what we call constitutional symptoms. And typically it's the ones which are caused by cytokines, so hormones released by the, typically myelofibrosis, but also in the other myeloproliferative conditions, interleukins in particular, which cause things like night sweats, fevers, weight loss, and probably slightly a different category of causes, bone pain as well. And these, until the JAK inhibitors came along, were very, very difficult indeed to treat. Sometimes they do improve with steroids, but of course people don't like to be on steroids for long periods of time. Bone pain can be a very difficult symptom. It's not common, but well, certainly debilitating bone pain isn't common, but aches and pains, which may be related to bone pain, is quite common. Sometimes it's related to the different cells in the bones which regulate the uptake of bone becoming unbalanced. And then things like bisphosphonate infusions, so things like Zometa can be helpful in that. Sometimes it's due to inflammation of the lining of the bone itself, the periosteum. And for that, sometimes steroids and low-dose radiotherapy can be effective. It depends what the cause is. But again, all of these symptoms often do respond very well to a JAK inhibitor. So we've got, for most patients, we can now access ruxolitinib, certainly for myelofibrosis. And certainly I've seen a lot of patients who've had these symptoms for years, almost not, well, perhaps not overnight, but certainly over a period of weeks, get marked relief from these symptoms. And so this is just a slide from the early COMFORT 1 study, showing how anything from night sweats, you can see the patients who got ruxolitinib are in green, had a marked improvement in their symptoms, itching, bone pain, as well as inactivity, which is a marker of lethargy and fatigue, as well as rib pain, so that's splenic pain, abdominal discomfort. So clearly in myelofibrosis, we've got good data that the JAK inhibitors, particularly ruxolitinib, are very beneficial. There is more data coming, which I think Claire's possibly going to talk to you later on in the evening about using JAK inhibitors in polycythemia, although actually at the moment getting access to that is very difficult. So that brings me to the end of my gallop through management of these symptoms. I can't get away from the fact that these are difficult to treat, and what I said at the beginning, as doctors, our medical approach to these things has often in the past not been very satisfactory at all, and all of the other kind of lifestyle modifications are actually a lot more effective. There's lots of different symptoms, there's lots of different causes. It is, as I said a few times, a matter of having that discussion, trying different things, and being open and honest and clear, and not hiding symptoms, trying to be really quite upfront. These are the symptoms I've got. What can we do about it? And trying different things and seeing what works for you. Right, I think I'm out of time, but thank you very much.
John, can I ask you to stay down the front? Louise and Ange, would you like to come back and join our panel? I'd also like to invite down to the front Nicola and Rosie. So Nicola and Rosie run a fatigue clinic, I believe. Possibly to start things off, could one of you maybe just say one or two things about what you do in your clinic and how it works?
Hi. So I'm Nicola. I'm a physio by background and Rosie's our occupational therapist. So what we run here based at Guy's is we run an outpatient service that is really, it's a symptom-based service. So it's not just for fatigue, it's actually for any symptoms that really impact on someone's physical function and health and well-being. Fatigue is obviously a large symptom that we do see within our clinics. And within that, I guess particularly what we've noticed is that we get really two types of fatigue presentations. We get those who experience fatigue that really impacts very highly, severely at a constant level. And for those patients, we tend to have more of a graded exercise approach, and we have a rehab program that runs over 8 weeks of supervised exercise and provision. And then we also have the experience of those patients who actually, from an activity point, they're doing lots and lots in the week. And actually they need a different approach to their fatigue management. And it's more looking at sort of other strategies and activity planning and how they plan their day by day in that week. So we've got sort of two approaches to our clinic depending on how the symptoms present.
This is the point at which we can have some questions from you. I'm sure a lot of the talks that we've had so far might have triggered some thoughts amongst you. So is anybody in the audience like to ask something to one of the people on the panel? Yeah, we have a gentleman up here. Can you just speak into the mic so we can all hear you? Thank you.
Yeah, my name is Samuel Miller. I wanted to ask Louise about, she talked about really severe itching, and then she talked about what she has done, the program that she's worked on. How effective has that been in terms of the itchiness that you currently experience?
For me?
Yeah. For you?
Thanks. For me, totally effective.
So you have no more itching?
On occasion, if I have to put a pair of tights on to go out somewhere posh in a dress, but most of the time I try and wear trousers. No, I can honestly say it's gone from 110% to 5%.
Thank you very much.
Andrew, you've been monitoring the internet traffic while we've been talking. Do you have some questions that have arisen during the course of the evening?
Well, first of all, I just want to say that a gentleman wrote in from France, and he was touched by your 3 stories. So we really think that we have people watching from Australia, where it's 4 a.m, and Taiwan, and Denmark, and Ireland, and I think even India. So they're all in these cameras watching, and you make a big difference. Just so I understand about fatigue, though, and John, you had spoken to me about it, but for the ladies, more exercise, it's counterintuitive, but doing exercise now for cancer patients and ours is a good thing. Am I right? Yeah.
I think it largely depends on the individual. I mean, we've all said tonight that we've had a complete turnaround of lifestyle. I had quite, I wouldn't say hedonistic, but I was quite naughty. I smoked a lot. I drank a lot. I was quite overweight. Well, I'm getting there, but I think, like I say, it depends on the individual. I find there are days where I can go out and do a 7-mile run, no sweat, and then the next day I'm completely useless. So I think it's just a question of finding the right balance for you. Everybody's different. I mean, I do suffer quite a lot from bone pain, but then I do find generally after exercise I feel really good. So it's all about, you know, the endorphins and the dopamine levels and everything else. It really helps. And I just think it is pretty much a lot of it down to lifestyle, exercise and mindset as well. But
Does that go along with your clinic too?
I'll try and talk, but I'm losing my voice, so I'll apologise now. But I think me and Nick had a bit of a conversation before we came today, and actually what's really important is getting to know people and looking at exercise not necessarily always as that run, but actually what is it that you enjoy, and looking through the day at what you do that is already exercise and how to grade that up. So planning is really important, and what we normally do in a first session is just get to know people, get to know what's meaningful to them, what well-being is to them, give them a bit of time to go home, plan and reflect and look at their life. And then it's working out the triggers, the things that improve things, the things that make things more difficult, and how to balance that and getting a sense of control. Even though we might not be able to get rid of the fatigue, it's actually, are you better being able to be busy with fatigue, feeling positive and having a control over that, than sitting at home feeling like you can't go out and do the things you want to do. And that's kind of the ethos we work around. So I think it's just emphasising how personal it is to everybody. And I'll stop talking now because I think I'm about to run out.
Sorry, I'd just like to add a little bit more to that. I actually have, I run 2 businesses and I have a job 2 days a week. And what I find, I'm a sports massage therapist. When I'm actually working, I'm working with people, I actually feel better. When I'm sitting at an office 2 days of the week, and it's only 2 days of the week, I feel so lethargic and fatigued. And I just think that it's interesting how when I'm up and about and blood is flowing and I'm moving, so I'm not saying that everyone needs to go and run, and just like absolutely amazing. I've seen such a transformation. She's actually running a 10-mile run. I'm just like, I knew this girl when she didn't run. And, but if walking, whatever, I do believe that actually sitting down, the chair is killing us. It really isn't good for us because you're obviously not moving around. That oxygen's not pumping around your body and you're going to feel tired. You're going to feel more fatigued.
Can I ask a question of Dr. Lambert? So some people know I have myelofibrosis. I was diagnosed 3 years ago, and I haven't had the fatigue yet. And I was able to run 30 minutes today, which I feel, I don't want to say feel guilty about, but I feel badly some. But I also worry, is another shoe going to drop? Like, will something change in my blood, and some of these symptoms that I haven't had will, and oh my God, what will I do then? I worry about that.
And I think that's a reasonable concern. We know these diseases do have a tendency, they can change, they're dynamic. That's why, for instance, people who are on medications, we need to monitor it because the underlying tempo of disease can change and symptoms can change. Having said that, if you've got a good quality of life now, I don't know what medications you're on, but if you're being treated for the myelofibrosis as well, then we know that they are good treatments for the symptoms. So actually, there's no real reason. We know from the comfort data that actually, if you've responded at the outset, there's a good chance you'll carry on responding. So I certainly wouldn't be unduly concerned that you're going to get all of these different symptoms that we've alluded to. I mean, different people. I think the message is that the diseases are they're a wide, heterogeneous variety of diseases, and different people get different symptoms. So if you haven't got lethargy now, I'll be reasonably confident that hopefully you won't get it in the future.
More questions in the room? Yeah.
The word itch has been used a few times, but when it's been described as something that's other than an itch. I've got some itchy jumpers at home, but my wife, who suffers with the disease, has much worse symptoms than that. And I wonder whether the word itch should be lost from the diagnostic and assessment of these conditions.
Good point.
Because it communicates one thing, but the experience is very different.
Yeah,
and
very
I
good point.
whether something similar applies to the word fatigue, because everybody gets fatigue after a hard day, but what MPN sufferers have is something that's much worse than that description. And I wonder whether we need to work on some of the terminology that we use, because it would make everybody's life a lot easier. Because saying, I can't come to work today because I've got an itch, or I've got fatigue, just doesn't cut it.
Yeah, okay, for the benefit of the guys on the web, very briefly, the question is about whether we should use a different terminology, because simply saying itching or fatigue really doesn't cover what we sometimes feel. So I think some members of the panel would like to respond to that.
Well, I would say in my typical fashion is it would probably be too much of a description to say self-flagellation with barbed wire and ants. Yeah, so absolutely. Itch is quite an accurate description. However, it does feel like you're being rolled with razor blades and you can't do anything about it. But unless we invent a new word, I would say, personally, you can't really describe it in layman's terms to anybody. anyway, and nobody, without any condition, let alone this one, like I say, you have to select your audience, and I would say it was a fairly accurate description of how you feel, although probably doesn't even cut the mustard to say the word itch. But
can I just ask you something? I got to interview Ange a little while ago, and you've been an office manager, and you had difficulty at work because you had fatigue and you felt it wasn't understood, and I think you were talking about a work life too. So how do you communicate now in your professional life some of these symptoms you have, and that it's real and it needs to be taken seriously and they need to have some compassion?
It is very difficult. I mean, I worked for a very big corporate company in London. I worked in the same industry for 15 years. And it's all about performance and bottom line numbers and profits. And they really weren't interested in my well-being. It was just how many hours a week I could work. And I got to the diagnosis. I told my boss that I had this horrible disease. And she said to me, "Well, that's awful. Go and get me a coffee." That was her answer. She was a bit like, Devil Wears Prada. So I'm really fortunate, and I'm not quite sure why I've been so lucky, but I've just started a new job 4 weeks ago for a big law firm in Hampshire, and they believe in work-life balance. And I think a lot of employers now are going down the route where actually, if they're going to invest in people and train people and pay people to do a job, it's in their best interest to make them want to stay and also support them when they do have illnesses. And that can be anything from depression, diabetes, and even, cancer, strokes, anything. And I think that's just something society accepts more, and the more knowledge that people have about these conditions, there's a lot more understanding. But like I said earlier, you've got to pick your audience. I wouldn't stand in the tea room and say, "Well, guess what? I was itching so much last night, I nearly scratched all my skin off," because people aren't interested. So I think it's important that you choose the right people to tell, and that would be, your HR department or your line manager, and then, just get the facts out there. I've got this condition, I need regular treatment, I do have symptoms, some days I can't keep my eyes open, but it's not a performance issue. It's just how it is.
Can I quickly come back on that? Because I think the language is important, because it's not just the people that you work with, it can also be your GP, who has read that PV causes itching. He's got an itchy jumper at home as well. That's the itching that he's thinking you're experiencing. I quite like the blowtorch scenario. The blowtorch, and I think the word lethargy was used a number of times as well, because that moves it on from the common language that everybody experiences to something that they might actually start to take people seriously.
Could I just come in?
Dipti, I'm sorry, there's Dipti put her hand up just now. I wonder if she's got something to add to that. I'll come back to you in a second.
Yes. Sorry about that. Can you hear me?
Yeah.
I think one of the things is about the language and understanding. And an itch to one person isn't an itch to the other. And I think one of the things we're learning as physicians, and one of the reasons for having these assessment forms and the scales, is to decide when it's debilitating. Because fatigue and tiredness and lethargy could mean the same thing, and it's the degree in which that person feels it and the impact it has on their quality of life. So there's this issue about not reinventing words, or perhaps finding the right words, but I think we're really focusing on trying to quantify that. So I will write, if a patient does have the awful, debilitating pruritus that's have an impact, that will go in my letters. So I think one of the things is trying to get this so we don't develop a whole new language, but getting those assessments done to then develop a language in prognostic scores that will help. Because you're right, there is an itchy jumper and, all the rest of it, but how many words do you reinvent? So I think hopefully with all the assessment work we're doing, and then we're starting to look at scales, that may help that particular patient. That's what we're hoping. And again, it's like talking to your HR and getting people to understand your disease and the impact it has on your quality of life.
Thanks, Dipti. Louise, you wanted to say something?
Yeah, I just wanted to say, really, I think how lacking in knowledge our GPs are with these orphan diseases that people have. I saw 2 GPs, and I've been a patient at our surgery for 25 years, The first one who actually died, I had to take myself off for a blood test because I had hepatitis about 18 years ago, and it was only, I'd had headaches and these awful symptoms, but it was only when I got the pruritus that I recognised that it must be blood related, because I had the same itch with hepatitis. And so I was fairly lucky that I said, can I have a blood test? And then I was diagnosed. But my GP actually told me, when I asked him what polycythemia was, he actually told me to go home and Google it, because you can find anything on Google these days. The other lady GP I had said to me, I have hundreds of patients on my books with polycythemia. You'll be fine. And it turned out a year later that she admitted to me she knew absolutely nothing about polycythemia, and I was the only one of 2 in the whole of the South Lakes that actually had polycythemia. So, you know.
Can I just pick up on one point, actually, from Andrew's story? I'm sorry. Which is the point about not trying to do too much. So having laboured the point about exercise, which I think is very important. Sorry?
Hold the mic a bit closer.
A bit closer. So, having laboured the point about exercise and the importance of doing that, there is a clear second group of patients who I see who are debilitated by fatigue, and those are the people who are trying to do too much. Those are the people who are working, the city high flyers. They're people who are doing very high pressure jobs and can't take the time off. And actually, I think it's really crucial that if you are struggling to get your energy levels back, to be able to do what you want to do, it is a matter of reprioritising, to work out what is really important. If that's your job, then fine, but see whether you can reduce the hours or reduce the intensity. Or if it's other activities which you would normally be doing, can you reduce them? Can you delegate them to somebody else? So yes, it is important to do exercise, but it's also important to conserve your energy at the same time and limit yourself to what's really important.
I'll just make one comment. More around work, because we do have a lot of people coming in that are still working, and it's those conversations with the employer. And I think that we've probably all heard the term unreasonable adjustment. That's a very waffly term that's talked about a lot. So I think it's thinking really practically what that is to you, and going to your employer with ideas and seeing where you can meet each other halfway, or actually if you're going with the ideas, more often than not we do find that they take that on board. Seeing if you can get professionals to help you within that, and trying to make those positive steps to being able to continue in work if that's something you want to do, or reprioritising if it isn't. But I think it's seeking support and thinking practically a bit.
I have a question up here.
A question for Dr. Lambert. Once you've identified somebody who's got myelofibrosis, what are the symptoms within parameters of general symptoms that you look for before you subscribe the JAK2 inhibitor?
So, as in which symptoms would I ask the patient about?
Sorry?
So, which symptoms would I ask the patient about?
Yeah, you've identified somebody with myelofibrosis, but everybody with myelofibrosis doesn't get the JAK2 inhibitor.
So, it's particularly for patients who've got the constitutional symptoms. I mean, the data that we've got from the big studies are those who are in the highest risk groups of the myelofibrosis patients. So those are the ones we often think will benefit most. But certainly if patients have got debilitating symptoms as well, particularly the weight loss, the splenic symptoms, the lethargy, those are symptoms that we know will benefit from ruxolitinib. So those are the patients I'll be having the discussion with. Having said that, of course, these drugs do have side effects. They can potentially push blood counts down. And if that is already a problem, for some people with myelofibrosis, that is already a problem. So it can actually exacerbate the situation. So it's a matter of trying to get the balance right between trying to improve symptoms without necessarily making their blood count problems and other issues. It can increase the risk of infections as well. So we're trying to avoid those problems. But yes, symptoms, all those symptoms we've talked about are ones which would be relevant to this discussion, yeah.
We might have time for one more question. I think this gentleman here put his hand up first, sorry.
Hi, I'm actually a patient of Dr. Lambert, and I was diagnosed about 2 months ago with PV. And I've come to understand that it's rare and somewhat individual. So I was surprised, Ange, that you alluded to family that had it. Is there any evidence that this is genetically inclined?
Well, obviously I've done a little bit of research, and being under the care of Professor Claire Harrison initially, I think the consensus is it's not known to be hereditary, but because we've identified there's an anomaly in one of our genes, that it's something common in our family. I know there are known cases of other people with family members with the same disease, but as far as I'm aware, it's not known to be hereditary. Is that correct?
Claire, do you want to add something to that?
Yes, there are some families that have got PV or MF or ET or actually mixture of these disorders running through them, but it's very unusual, especially a family like Angie's family with so many members that are so close together. But what we also heard Ange say was, I'm one of 48, was it, grandchildren. So that's a huge family. I'm one of 6 grandchildren, which is probably a bit more reflective of a normal sort of 21st century family size. Sorry, Ange, sorry. No offence.
Not that you're weird or anything, Ange.
Anyway, I think it's great that you're part of a big family. And so
right.
That's one point. The other point is that we do know that there are factors that increase risk of inheritance. And there has been quite a lot of work done, and we're keen, for example, to collaborate with Professor Skoda because he described a lot of these genes, but most patients will not have an affected family member. The advice also is that you don't need to run off and get your children tested or your grandchildren tested or your brother or your sister, but if they have a blood count done, it's worth asking them, was it normal? The chance of a family member like that being affected is less than the chance, greater than the chance of them being struck by lightning. So it's greater than about 1 in 30,000.
Of course, there are other reasons that you might have multiple members of a family affected by these diseases, because, I mean, we don't know what causes them yet. Professor Mary Francis will be hopefully telling us a few things that might be indicative of the causes of the diseases. But if I was diagnosed 16 years ago myself. We don't know why I've got the disease any more than any of the rest of us have, but whatever caused it might have caused it to people in your family at the same time, possibly. And that might be one of the reasons that we see these groupings within families. We don't know yet, but it doesn't necessarily have to be inherited for there to be connections between family members. That's the one thing I would say. So we're kind of running out of time on the panel discussion now. Thank you very much for your input. There should be plenty of opportunity later on when we break into our breakout groups to discuss things that have arisen during the course of the talk. So hold your questions till then, and then if you still don't have time to answer your individual questions, make sure you write them down on your forms which are in your packs. Okay, thank you guys. If you'd like to... and if I could ask Mary Francis to come up for her talk. You okay with this one? All right, good.
Thank you very much for asking me to speak here this evening. And I'm going to tell you a little bit about a pilot study, Mosaic, that MPD Voice have totally supported, and then give you the results of one bit of it, which may not be what people are expecting because it's about the quality of life results, but it's the bit that's out and published. So we, in particular, I got involved some years ago with a couple of MPD people and an epidemiologist who's a person who's trained in studying what goes on, why people get disorders, what are the things in the environment or in their background that may lead to them getting disorders. And we were interested in myeloproliferative disorders. And the first thing we did was, again, using the epidemiology training, a systematic review. You look at all the literature that's ever been published, and you look at all the studies, and then you see what is out there, what information was there. So doing this, we started out with 9,156 articles in any language that filled the bill, and then we went down and screened them. And actually we ended up in the end that there were only 19 studies ever that had been done looking at the causes or the epidemiology in the myeloproliferative disorders. These studies were, I'll explain a little bit further about the types of studies, but there were 13 case control studies and 6 cohort studies where you just take a group in a particular profession and you look at what diseases they get. So that was actually very little information. And then we did a survey and we analysed all the data of what was there. And we found a number of occupations that seemed in these studies to be perhaps associated with the myeloproliferative disorders, and I've listed them there, and they're an interesting lot. Things like shoemakers, and some of them you might expect, but some of them not particularly. We also looked at other information, and there were a number of medical conditions in the published literature, the antecedent medical conditions that the people had before they were diagnosed with their myeloproliferative disorder, and some of those were associated with more likely to go on to develop a myeloproliferative disorder. But this was all very vague. The numbers of these studies, some of these studies, that somebody could publish a study with 39 patients in it. I mean, they were really tiny, lots of different methodology. You look at this and you were sort of said in the end, well, okay, but just because I'm a cook, does that mean I'm going to get a myeloproliferative disorder? Almost certainly not. This is a small statistical difference. So we decided that there was a huge need for looking at this further. And we set up, but there were lots of different ways of doing this. So the first thing we had to do was look at all the different things and do a pilot study to see all the different things and how they would work. And we were very fortunate in that MPN Voice were interested in this and funded us. So we set up myeloproliferative neoplasms, an in-depth case control study known as Mosaic. We actually spent ages thinking that out. And we got lots of different people involved. Leslie Anderson is the epidemiologist, and Andrew Duncan in Southampton, another haematologist, and the two of us were the haematologists. And then all these other people, Ruben Messi, you'll know, but also there are people called occupational hygienists and people who spend their whole life looking at the epidemiology as to how what sort of things people have been exposed to. And we got all these different people involved, some of them in Australia, in the US, and set this study up. So it was an exploratory case control study, because that's what we decided. We thought 100 patients would be good, and we wanted to get controls. Now, getting controls for these studies is really important and really difficult. So we were looking at what would work best, getting the patients to recruit controls, get your non-blood relative, like your wife or somebody else of the same sort of age, or would it be better just to go through the GP databases and ask people to do it? And we looked at lots of different procedures, and we looked at collecting samples, and then we also looked at the quality of life. So you've heard lots of the quality of life, but we actually looked at that while we were doing this. Patients were recruited by the usual sorts of criteria. They had to want to do it, they had to be able to do it, etc. And then we set the study up, and it's now complete. But what I want to show you now is the information, because this bit is finished and analysed, from the quality of life. So you've heard all about this questionnaire, the MPN SAF. It looked at the time we were running, it was 26 different points, and all the patients were asked would they complete this when they were recruited into the study, and as they were doing their telephone interview, which was how we got all the other information. But we did something else. We also got the controls to do the MPN SAF. Now, that's never actually been done before. We've heard all about these patients, and everybody knows about the symptoms. But what we thought would be interesting to look at would, what about the controls, the other people, and who were allegedly well, or certainly not people with MPNs, what was their quality of life? So all of that was done, and you know all about this questionnaire. I'm sure many of you have done these types of questionnaires where you look at the spleen proliferation related, the vascular, the psychiatric, the cytokine, and then the overall quality of life. This was a case control study, and I've explained about getting the controls. And in the end, what groups did we have? Well, we actually over-recruited. By the time we finished, we got 106 MPN patients, and I will refer to them as the MPN UK patients. They were recruited either in Belfast, in Northern Ireland, or in Southampton, because that was the two centres. Interestingly, controls, we only managed, we would have liked 200 controls, 100 GP ones and 100 patient recruited ones. We struggled and got up to 124, and the first answer for that is to take this forward. It's really difficult to get GP controls, to get people who are randomised, and it's probably not worth pursuing, whereas getting the patients to get some of their friends, family, to get people to do this works, and we got a reasonable number of those. And then we also compared our data to what I'm going to show you, to what I call the MPN Mayo patients, and this is 1,446 patients which have been referred to in other studies who have had their quality of life looked at. So we compared our quality of life data to that cohort. And what did we find? Well, this is what we found. This is each of the symptoms, and you can see, looking across this, you have in red are males, and in green are male controls, and then in blue are female cases, and in yellow, female controls. And what you see is that the patients have highly significantly more symptoms than the controls. So that's never been done before. You all take that as a no-brainer. But actually, that's very important when your GP says about these symptoms. They're very different from age. These control groups are the same. They match very well across age and sex. Next point from this is females have much higher symptom scores than males right across the whole spectrum. And basically, in 25 out of the 26 things, the patients came out higher than the controls. The only one they didn't was fever, which makes sense. People, you're not really going to have fever all the time, although that's in all of these controls. The next thing we looked at in our group, we actually were able to do this, is look across the symptomatology by the different subtypes. And you can see that we 37 PVs, 15 BTs and 14 MPFs. And there are differences across the different subtypes, and the myelofibrosis have the worst symptom scores, which is, of course, the same as what people get in all the other different things. This is a thing called a spider plot, which I think is a very nice diagram. And what you do with this is you plot on a circle the scores for each group. And in red, you have the scores for the MPN UK patients, and that's compared to the controls. And you can see on this that the patients have much higher scores right round, although it varies, compared to the controls. But the other thing we did is analyse our cohort against this MPN Mayo cohort. And when you do that, you can see that the UK patients and the big cohort are almost superimposable, that there was very little difference between the UK patients and the MPN Mayo cohort. So the group that we're picking up in the UK have the same symptomatology as the much larger group. The only difference is UK patients had less early satiety. That means that they did not complain to the same amount that they were full up. And of course you can make all sorts of comments about Ruben Mesa would about people in Texas and what they eat. But the UK people don't seem to complain that they fill up and can't eat enough as much as the rest. But otherwise they were same. I think that's very useful to show that there's no difference. So the main conclusions from this study, quality of life was worse in MPN UK patients compared to controls, never been done before. MPN patients had higher mean scores than controls for 25 of the 26 symptoms measured. Fever was the one where there wasn't a difference. Fatigue was the most common symptom, perhaps as you might expect. Female MPN patients suffered worse symptom burden than male patients and substantially worse than female controls. And UK patients compared to Mayo Clinic patients had a similar symptom burden with lower satiety. So, just finished the study. The PhD that our student has just been submitted, but this particular, I forgot about myelofibrosis reported the worst symptom, but this particular paper with all this study is actually now published. It's been accepted and it's published and listed on PubMed. So that's the end of the early results. However, we do have from this now lots of information as to how to go forward. We are in the process of trying to raise enough funds to run a much bigger UK-wide and much beyond study, because to really get hard epidemiological information, you need to have about 1,000 patients and about 2,000 controls. However, the data from this study, the epidemiological data, is such that that will roll over into the big study, even though we haven't got enough information, and we knew that, to analyse the epidemiology fully with 100 and 124 controls. It was set up that that will contribute to the bigger study. So thank you very much.
Thank you, Mary Frances. Thank you very much. It's encouraging that the funding that we managed to arrange for the study has been successful so far. Very good. Thank you. Right, okay, Claire, your turn. Finally.
Wondering why Mary Frances didn't get any questions. Maybe
We haven't got time.
At the end. Okay.
That's the reason.
Super quick.
So
I'm really sorry. It's very hot in this room. We have got all the doors open. But if you do want to, if you can just hold on for a little bit longer, we've got cold drinks in all the breakout rooms for you. So welcome to Guy's Hospital. Thank you for coming on a rainy day. And thank you for waiting until nearly the end and staying to listen to what I want to say about new drugs for MPN. I'm going to be very fast. And it's a challenge to be fast because we're in quite a happy position. We have got lots of new drugs and lots of data. But I'm going to have to give you a whistle-stop tour. Concerning ET and PV, we know a lot about current management, but our management, the complete knowledge and evidence base for this is lacking, and we still want to do randomised studies. Right now, the randomised studies that we really want to focus on, first line, are comparing interferon with hydroxyurea. You might say, why are they doing that? These are really old-fashioned drugs. I bet most of you in the room have had one or other of these drugs. We really need to understand which of these is better for which patient and when. And so we do have at least one ongoing study across the world. This is the MPDRC study, which is being run by the MPD Research Consortium. But there are also is another study with the AOP Pharma interferon. But for UK and many other international audiences, this is a study that may be open in a centre near to you. And watch the space for the answers to that study. Otherwise, we've been focusing our questions in terms of treatments on patients who don't do well with either of those two drugs, particularly hydroxyurea. And we've been looking, of course, at JAK inhibitors, specifically ruxolitinib, which is the first available JAK inhibitor. Recently, the results of this study, the RESPONSE study, were released, which is a study comparing ruxolitinib with so-called best available therapy, whatever your doctor chooses to treat you with, for patients with PV, a big spleen, and still needing phlebotomy. We haven't had the chance to discuss these results in a UK forum at great length, so I just want to whiz you through a few slides just showing these to you and trying to pose some questions about the data. So the end point of this study, what was measured was reduction in spleen size and avoiding the need for venesection. And there were more patients who hit both of those endpoints treated with ruxolitinib, you can see here, but quite a low number overall, only 1 in 5, but only 1 in 100 of the control patients. If you split these two endpoints out, you can see still ruxolitinib winning, but it's not winning in 90% of the patients. These are still positive results.
And they're positive results if you look at other facets as well. So the thing we talk about, the thing Dr. Radia, my colleague from here, mentioned, we're really focusing what's your blood count doing. What's your blood count doing was better for ruxolitinib than the control arm. And also symptoms were better managed or improved more for ruxolitinib treated patients than for patients treated with best available therapy. And on this slide you can see that we're dividing out the whole SAF, so how many patients had a 50% reduction in their total score, and then these individual components of different symptoms. So ruxolitinib treated patients doing better on all of these facets of management. So the conclusions from this study are that ruxolitinib is effective and safe. I didn't show you safety data, but there were no new safety findings. And as a consequence of this study, in North America and also in Europe, this agent has been approved for patients with PV who are not responding to or are intolerant, that means getting side effects, to hydroxyurea. However, in the UK at the present time, there is no access to ruxolitinib for PV patients because beyond it being approved, it also has to be reimbursed, and that means it has to be assessed by NICE. And there are also some small medical comments that I would like to make about this study. The population of patients was very limited. We have a very large clinic here. We could only find 6 patients. And I know that my colleagues across the world had the same problem. So we were looking at a small population of patients with PV. The control treatment for many patients was hydroxyurea. So why did we compare hydroxyurea when we knew these patients weren't doing well with hydroxyurea? That's because, as you well know, there aren't very many choices, but it means we need to be thinking when we're interpreting the results. And so I think we need more information about this drug and its usefulness and its safety in a broader group of PV patients. And we really need to understand, what does it do for blood clotting? What happens about transformation to MF and to AML? And more longer-term data on safety. This drug has not been around very long, and we really need to understand about safety. So there are a number of ongoing efforts to understand that better, and one of these is the MAGIC study, which is a UK-wide study, and I know there are some patients in this room who are on or have been on this study. So this is a similar idea, ruxolitinib versus other agents for patients who haven't responded to hydroxyurea. We're recruiting lots of patients and we've done really well. We've only got PV slots left. We've filled all our ET slots. And we're likely to close the study towards the end of the year, but we will be following our patients up for much, much longer. We'll be following them up for 5 years to answer those questions about thrombosis. Now I want to turn to talk about myelofibrosis. What things might we do beyond standard management, and what else are we thinking about for patients? We've had massive improvement for many patients with myelofibrosis with the advent of ruxolitinib. We talked a lot about symptoms. That drug's very good for symptom control. We've learnt a lot about how can we transplant patients, and I'm sure in the myelofibrosis breakout group we'll be talking about that. The next JAK inhibitor to come along and to have results is pacritinib. So I just want to very, very quickly show you the results with pacritinib, which has just finished a study called PERSIST-1. PERSIST-1 showed that this drug is effective at lowering spleen size. So on this side of the slide here, all the blue lines are individual patients treated with pacritinib. On this side, all the grey lines are patients treated with best available therapy. More patients having spleen reduction. Here's the symptom improvement. So blue, i.e. pacritinib treated patients getting reduction in symptoms, which is durable compared to the control patients. We expect to see lowering of blood counts with ruxolitinib, but one of the differences with pacritinib is we don't see so much reduction of blood counts. So here is the change on the left-hand side in hemoglobin, pacritinib patients in blue, control patients in grey, and the platelet count here. So for ruxolitinib, we would expect to see about a 40% fall in platelet count. And we didn't see it for pacritinib-treated patients, and we didn't see it even for patients with a very low platelet count. So this might be an important aspect for this drug. We also saw some patients becoming independent of red blood cell transfusions, so really improving anemia. So this looks like an interesting drug, but we're still studying it. And we've got another study called PERSIST-2, a bit like COMFORT-1 and COMFORT-2, if you like, that is still open for patients with low platelet counts. Otherwise, another JAK inhibitor drug, we've got lots of drugs with very unpronounceable names. This is momelotinib. This drug appears to improve anemia. It can cause, however, numbness of the hands and feet and lower blood pressure. That suggests that it might work in a different way to the other JAK inhibitors. And this drug is also available throughout the UK in 2 studies. These studies are called Simplify 1 and 2. There isn't very much simple about drug trials, believe me. But essentially, we're asking the question, is this drug better than ruxolitinib in Simplify 1? And can it help patients who aren't doing well on ruxolitinib in Simplify 2? I don't know the answers to the questions here, but I'm looking forward to seeing them. Otherwise, other new drugs that we might be looking at are listed on this slide. I'm not going to go through them, don't worry, but there are lots of them. So I think it's a reason to be very hopeful right now that we will find something that's very effective. A drug of interest is imetelstat. There is a study with imetelstat opening in the UK at the present time. And another drug of interest, I think, is this drug called PRM151, which is an intravenous drip, which is supposed to inhibit fibrosis formation. All new data, all exciting stuff, all reasons for good hope, I think. We're also combining different drugs together because it's very common for us to need to use combinations of drugs to treat blood cancers. And so we're moving forward at a great speed. This is nearly my last slide. This is what we call our trial portfolio in the UK. Dr. Lambert, Dr. Radia, Professor McMullen, Dr. McLaunan, who's at the back, and I, and about 15 or 20 other doctors, scientists, nurses who are interested in MPNs, run a committee which oversees these trials, which looks at developing newer trials. MPN Voice has a seat at that table as well. These are many studies that are ongoing in the UK at the present time, and I'm happy to talk to you about them informally after this. But I want to close with this view from this building. For those of you who are watching over the internet, you won't have seen perhaps the splendid view from the top of Guy's Tower. This is what it looks like on a blue sky day. It's not a blue sky day today, so unhappily. This is Guy's Tower. This is where we currently are. But I think the landscape of MPNs is changing much like the landscape of London has changed rather massively and offers very many exciting future possibilities for you patients. So thank you for your attention.
Thank you, Claire. When I was diagnosed, we didn't even know about the JAK2 mutation, let alone there being any drugs to inhibit it or inhibit its effects. So I think Claire's absolutely right. I think the emerging landscape, as she put it, is very encouraging for us. And one thing I always say is, isn't it great that doctors like Claire and her colleagues, some of whom are here in the room, are spending their lives, their professional lives, looking for cures and effective therapies for these illnesses. So I think it's a very positive outlook. Now, Marilyn Webster is going to stand and give us a few minutes update in terms of fundraising for MPN Voice. We do some amazing things. I mean, I say we. I actually, take pretty much a back seat on this stuff. You guys do some amazing things to raise funds for our support group. And Marilyn's going to tell you a few things about those things.
Okay, thank you.
All right, thanks. Here's the mic, if you could hold it as close as you can to your voice. Yeah.
Well, I just want to say on behalf of MPN Voice to all the MPN Voice community, watching on the television, watching on their computers, sitting here with us, you are amazing. And thank you so, so much. The big thing is, up to date from January to today, we have raised nearly £60,000. Fantastic. And I would just like to say to all those people that have pounded the streets, that have swum hundreds and hundreds of lengths, that have thrown themselves off buildings, and have walked and cycled and have done amazing things. Thank you so much for all the effort, for all the training, for everything that you're doing so that we can fund research that is going to find that cure for us. Because I've got ET, we've all got something, an MPN, and we want to find that cure. So thank you so much. And I would like to say a special thank you to some of the members of the running team, the MPN Voice running team, who are in the audience today. I can see John Messenger, and I can see Giovanni, and I can see Jerry Burns. And I would just like to say the running team have been absolutely great. They themselves have raised just over £12,000. So that is fantastic. So a gauntlet has been thrown down. We've got to raise some more money. They want some more money for their epidemiology study. So what are we going to do about it? Are we going to... Well, yeah, we're going to do some smaller things as well. We're going to do some craft fairs. We're going to do some dress-down days at work. We're going to do some... There's a head shave happening this weekend. We're going to do lots and lots of little things as well as the great big challenges. But today I would like to tell you about something that I would like you all to get involved in, because September, worldwide, is the national month for blood cancer. It's the blood cancer month. This is not just in the UK, it's worldwide. There's going to be, by some of the much, much bigger charities, lots of things on the television, on the internet, about raising awareness of blood cancers in September. And you can't get many more rare blood cancers than what we've got. So we need to raise awareness. We need to raise and shout about the fact that we've got these horrible diseases that cause us all those awful things that we've been talking about. And we need to raise awareness by talking to people. Let's get the chatter going. Let's get the chatter moving. Let's get everybody knowing what an MPN is. And let's make sure that when we go to a GP surgery, they can actually start to spot our symptoms rather than waiting for someone to have a heart attack or a stroke or something like that, or even worse. So what's the best way to get chatter going? Facebook. No, not Facebook, because a lot of people aren't on Facebook.
the best way to get chatter going is to talk. And what do you have to do when you're talking? You have to have tea, coffee, and cake. Very, very healthy cake, obviously, because otherwise Louise is going to look daggers at me. So, I would like to launch today the MPN Voice September hugiferous tea party, coffee morning, cake, whatever, but it's got to be in September. So I've put out a whole load of leaflets on tables. My printer died this afternoon, so there won't be in everybody's pack about it, but there will be in lots of people's packs about our coffee, tea, cake event in September. We're going to have posters for you that you can put out and give to friends. We've got some leaflets, and we've got lots of information and other goodies in our fundraising pack. So we can all do that. We don't have to be throwing ourselves off buildings. We don't have to be pounding the streets. We can maybe, if you can't make cake, you could buy a cake, or you can just get your friends involved. So let's get that chatter going. Let's get out there so that we can give the epidemiology study another £100,000. Let's make it £150,000. Let's get the answer to this horrible, horrible disease quickly. So thank you, everybody. You are amazing. The MPN Voice community is amazing. And I would just like to say, on behalf of everybody at MPN Voice, thank you so much.
Thank you, Marilyn. Okay, that pretty much wraps up the kind of the formal bit. We're going to break out into our breakout groups now. There's refreshments in each of the rooms, okay? So there'll be an opportunity to grab something to eat and drink in those rooms, or at least drink, I think. So the ET group will remain here in this room, okay? If you need to stretch your legs or go to the loo or whatever, take a few minutes to do that, but this is where we're going to be. The PV group and the family group will be back in the big room where we kind of gathered before we started. And then there's a smaller group just off to the left of the big group, which is where the MF group will meet. Okay? So ET in here, PV and family in the big room, MF off to the right. Okay. We don't. No.
Okay. What a great session. Don't go away if you're with us on the online audience, because we have some exclusive interviews with you, and we've been getting your questions, and please be sending them in still. We're going to interview Claire Harrison. We're going to interview Dr. Raudia. We're going to interview some other patients. So we'll still be with you. Give us a couple of minutes as things break up here. We've got to move our camera, and then we'll be back with more interviews for you. As you heard, we have people watching from all over the world, couple hundred people. So we're very delighted about that. Let's find out just for a second, how do you think the event's been going?
I think it's been very interesting, very interesting. I'm interested in how they will treat the criteria if there is drug trials.
Right.
Because I'm 80.
You're
and
80?
Yeah. So I want to know whether I'm out of criteria.
I hope not. Well, thank you for being here. Okay, and there are all the folks out there on the video. How do you think the event's been going, sir?
Very good. I think it's very good. So we've been to many of these, and we've found them very informative, and also we're thankful for all the consultants giving their time.
Yeah.
Been very
Really,
valuable.
really.
Thank you.
All right, we'll be back, everybody, in just a few minutes. Stay with us online. We'll be back live from London.
many different treatments may be used to control your disease. These agents are all very effective at lowering the blood count and reducing the risk of blood clotting events. They all have a different pattern of side effects, and so patients, about 20% of patients in the study, changed from one treatment to the other. In summary again, the treatments were all very effective. So if you do need to change therapy, or if you are experiencing side effects with the treatment, it's really important to discuss that with your doctor, because there are effective other agents out there, either used alone or indeed in combination, which is some other data that came from that study.
So yes, Dr. Ruben Mesa presented yesterday the results of the PERSIST-1 trial that compared pacritinib, which is a JAK2 inhibitor, to best available therapy in patients with myelofibrosis. The design was quite close to that of the COMFORT study we are now used to learn. We learned about the response in terms of spleen volume reduction, symptom reduction. So the design was quite similar to those COMFORT studies, and the result was positive, showing a clear advantage in patients receiving pacritinib compared to best available therapy. Of note, there was no ruxolitinib allowed in the BAT arm, so this study compared pacritinib to all the other available drugs. I think one important finding of this study is that pacritinib doesn't worsen thrombocytopenia, for example, in patients who are already thrombocytopenic at baseline. And as you know, we cannot use ruxolitinib in patients with very low platelet count, below, let's say, 50,000, for example. So pacritinib may be a response for those patients with severe thrombocytopenia. Another interesting finding was the proportion of patients who achieved transfusion independence for patients who were heavily transfused before entering the trial. So this could also be a bit difference with ruxolitinib. So probably a complementary, let's say, population of patients that could benefit from pacritinib compared to those who are beneficial, already have benefit from ruxolitinib therapy, for example.
Okay, here we are. We are now going to continue with some interviews for a worldwide live audience. This is Dr. Depti Radia,
That's right.
who's a hematologist here at Guy's Hospital, right?
Thank you, yes.
And we have a number of things to talk about to follow up for what was going on. First of all, I wanted to just go after some questions that some folks were sending in. One is about interferon versus hydroxyurea. And maybe, has it had a bad name? People were wondering in the UK, could it be used more often? I know it's a powerful drug.
Okay, so interferon in terms of patients with PV.
Yes.
Interferon's a drug that's been around for a long, long time, and we have used it for patients with PV in the past. Hydroxycarbamide, I think the bad name was around the tolerance, the fact that it's an injection, it has a side effect profile. But the data from Jean-Jacques Kilijan's group in France actually shows that interferon can make a difference to the disease burden. So we look at the JAK2 positive patients, and there's a different, what's called an allele burden, the amount of JAK2 positivity there's there. And interferon has been demonstrated to make a difference in reducing it, and in some patients completely getting rid of the JAK2. So from that, we will say that actually it stops disease progression if we're able to cut that right down. So for those reasons, we need to look at hydroxycarbamide interferon face-to-face again. That's what the MAGIC trial is about. So we would recommend younger patients try it, and we'd monitor them. But I think the bad name has been the fact that it isn't very well tolerated. And most patients, if they have it, after 6 to 7 weeks, quite a few can have the ability to tolerate the drug. But no, that's why the trials are started again. It's not an old drug. It's a drug that's been shown to have benefit for disease.
Okay, one of the other comments that came up in the session is people were saying, I don't think the word itch describes what we're going through. One fellow described it as a blowtorch, and one of our dear friends wrote in, Zenyak, who does the MPN Forum, says, well, why don't we just use the word pruritus? You know, why don't we just say that?
We do. All the questionnaires say pruritus. Pruritus describes a form of itch. The challenge here is these symptoms are really personal. So there are different ways. So you can talk about really bad itch. What does bad mean to one person? It's different. So we do use pruritus. It's what's in all the questionnaires. And I guess the medical term pruritus is the layman's term itch. So it's really difficult. So when I speak to patients, we'll say, okay, you've got an itch. How bad is it? And that's why I think those assessment forms are really, really important. Because if somebody's telling me that they're scoring 8 out of 10, that's pretty bad for that person. But we will end up having lots and lots of different names for the same thing, and that might confuse the issue a little bit more. So medically, it's known as pruritus. Technically, I will say to people, do you get itching? Is it pruritus? And I guess it's about us understanding what that means to an individual.
Okay. I want to ask you about the JAK2s and others coming. Excuse me. So you have ongoing data for ruxolitinib. I'm a myelofibrosis patient. I should disclose that I take ruxolitinib, although the dose has moved around. What if at some point that doesn't work for me, or there's some patients that it doesn't work for them off the bat? How will you decide whether if pacritinib is approved, where will that come in? How will you know which JAK2 for which patient?
Okay, now that's a challenging one because we don't know which JAK2 for which patient yet. So at the moment, all those drugs that are used on a trial basis, like pacritinib, momelotinib, and the other kind of SMO inhibitors that we're talking about, they have been used in a trial for patients that have failed ruxolitinib or haven't had the response we've been expecting. Hopefully from those trials, we'll be able to get a bit more information about which patients do better, which fare better. Is it just symptoms? Is it about anemia? Some of those drugs will cause... will cause more anemia and maybe drop the platelet count. So we need to learn more about those drug profiles in patients with MF and try and work out which cohort of patients they work in from the trials to then start making those decisions. It's really difficult right now to say which is going to be the third line or fourth line. We don't know yet. That's what the trials will hopefully tell us.
Okay, so what's your pitch for people considering being in a trial?
Actually, I think that it's a very personal decision. We have lots of trials running. I think the amount patients contribute being part of a trial is amazing, and that's where we get the data from. And if you're eligible for a trial and you feel that you can, because it's quite intense being part of a trial. I don't know if you have been.
Yes, I was in one.
It's intense, and there is a lot of data, and we ask a lot of questions, but it's from that data that we're getting where we are now. So we offer all our patients who are eligible for trials the information, and then it has to be up to the patient because it's quite difficult sometimes to, make sure you go for
One other question, whether you're in a trial or initial diagnosis, many of us have had bone marrow biopsies. It's not the most pleasant thing,
No.
right? Are we getting any kind of diagnostic tests that are easier on us?
Not to replace a bone marrow at this point in time. What we're getting are cytokine profiles and other things that we can do from blood tests, but we haven't got the diagnostic test that identifies a particular disorder. So JAK2 likely to be PV, depending on all the other parameters, but you have patients who have an overlap. So at the moment, in terms of a diagnostic test that makes the decision, bone marrow is there. There is talk about PV, whether it needs to be part of the first-line diagnostic tests, or patients who don't fit the criteria, should we do it as a reserve? So I'm sorry, but the days of the bone marrow haven't disappeared yet.
Okay, and one last thing. Many people have said they listen to you, they listen to Dr. Harrison, Dr. Lambert, others that we've talked to along the way. You are specialists in this disease, but many people have seen physicians who are not.
Yeah.
And they kind of bounce around, and they're not sure they've gotten the right diagnosis sometimes. What would you recommend to our listeners so that they get to someone like you, or they can feel confident in what they're being told?
Okay, so the first thing is, with the patient support groups, the community and understanding is getting better. It isn't level playing field wherever people are. So as Angie said, if you're concerned, you're entitled to an opinion. If you're concerned again, you're entitled to a second opinion. And there's a huge network internationally of MPN specialists. I'm not going to call us experts. We have seen enough patients so that if you contacted people, we will have people elsewhere in the UK where we would recommend somebody locally, and that can happen internationally. There's a massive network of clinicians out there with an interest.
Okay, I want to thank you so much, Dr. Roddy, how much you do at Guy's Hospital. And we're going to talk to one of the founders now who helped found your organization. Come on in. Step right in. These are our live interviews. Tamara, your last name again is?
Costa.
Okay, so you've been living with ET. Come close.
Yep.
Come close.
Yep.
So first of all, you live here in England. Where do you live?
I live in London.
Okay.
Yeah.
When were you diagnosed with ET?
I was diagnosed 19 years ago. So I was 26. That would have been 1998, I think.
Come over
something.
this way a little bit. Here we go. And so you were in your 20s.
I was 26,
and
yeah.
How did that diagnosis happen?
I was having a routine blood test for anemia, and they didn't find anemia. They found very high platelets. I have ET. And then immediately they thought it was a mistake because they were above 1 million. And then I had another blood test and then a bone marrow test, and they confirmed at UCH actually here that it was ET.
19 years ago. How have you been doing?
Well, touch wood, fine. I've steered clear of medication, which has been my number one thing. I was on aspirin until they found a few years ago that baby aspirin, when your platelets are that high, is actually does the opposite. So I stopped aspirin. I had a baby 2 years ago, which I never thought would happen.
Congratulations.
Thank you. So now I have not just fatigue, supposedly, but I have not
You have a
slept
baby.
for 2 years. So it's a whole other story. But yes, so I've lived with it for 19 years. And
I have to ask you this. So you were one of the founders of this organization, and now we have hundreds of people, and we have hundreds of people watching online.
And it's amazing to see. And it is the whole ethos behind this was when I remember being diagnosed and asking my doctor at the time if there was anyone he could put me in touch with, and there was nobody. There was nobody at the time he could put me in contact with, a younger person. And Claire and myself, a few other patients and some nurses decided that it was time that we managed to find a group to be able to get people together. And from a group that was next door to Claire's office, 7-8 people talking, we set up a website, and it grew and it grew and it grew. And today, I haven't been to a forum for a while because of the baby, but coming today, what was so amazing about the talks was also how positive they are and how that positivity has changed. It was all a little bit depressing in the early days, or not depressing, but people were really much more alone. And now there really is a community, as Marilyn said, and it is just how it's supposed to be. And that is just the best.
Well,
best
thank
news.
you. And this is a model, I think, for countries around the world.
Absolutely.
Okay.
Absolutely. Everybody needs each other, and it makes a huge difference, not to be alone, so it's not such a big deal anymore.
Well, congratulations on the baby, and all the best.
Thank you.
19 more years. Let's get Dr. Claire Harrison in here. As you said, Tamara was just saying, watch the wire there, Claire. We have our own little studio here. Dr. Claire Harrison, our dear friend, come here. So, first of all, Tamara was just saying, 19 years ago, she was diagnosed with ET, and then there started to be meetings after years next to your office, and now you have a couple hundred people, we have a couple hundred people watching, thousands of people see the videos. It's a community coming together. You must feel great, and also that you have more solutions to talk about.
Yeah, so I think many things actually, and I'm remembering the beginning of the story with Tamara. Actually, I was working in a different hospital then, and I was working in a little room off a corridor, and actually as we've discovered more, we've built a community. We work with you and with other people to build an international community, because that's actually really, really important, and that's one of the strong messages that I think has come from this evening and often comes across. There's a community of clinicians like Drs. Radia, McMullen and others who will be speaking to us this evening, as well as Dr. Lambert, Dr. Messer, Dr. Vostovsek, Dr. Teferi and others. So there's a big international community of physicians who are doing research, who also work alongside scientists like Tony Green, Ross Levine and others. But the patient community is something that we really can't underestimate. We learn so much from our patients. We learn so much by working together, and that's how we build progress in this disease, new treatments, and understand more about science. So I'm really invigorated by meetings like the meeting we've had this evening and opportunities to interact with the community, yes.
Dr. Harrison, I just want to follow up on some of the remarks you've made here, where you rattled off at very rapidly so much research that's going on, some for ET, PV, and also encouraging even for myelofibrosis, which I obviously follow closely. It sounds very hopeful.
Yeah, I think it's fantastically hopeful for you, our patients. At the present time, there's a massive amount of interest in science, so CRISPR technology, understanding about mutation order. So it doesn't only matter what mutation, but also what order you have them in, as well as different drugs. There's such an exciting time and such a promising time, I think, at the present moment. And that's really fertilised by a scientific advance in partnership with clinical trialists, in partnership with the patient community. And so I think all of this momentum is really building to something very, very strong and very, very hopeful for the future. And in fact, I think one of the people you're going to talk to next is someone who's a younger clinician, much younger than me, who's actually doing research in our department. So why don't I introduce her? Yeah. She's standing reluctantly at the back.
Tell us, who do we have here?
So this is Dr. Sama Alimam, who is, can you come a bit closer? Yep. Sorry. Who is a young clinical fellow in our department. I'm going to step round the other side.
We'll put you right in the center.
There we go. You're right in the middle, right where you're not so comfortable. Sorry. Who's going to be doing some research on our programme and is very passionate about patients. She's been reading a lot around the disease and has also been involved in referring our patients into the fatigue clinic and seeing a little bit about how we work here, working with...
Well, let me ask you a question. So I consider you one of the younger physicians in MPN, but here we have a new example. But are you feeling that in the medical community, it's an area that new physicians, new researchers are becoming interested in, and will have a steady stream to give us hope that there are people dedicated to us long term?
Yes, thank you for not calling me old. That's great. Yeah, absolutely. And we're trying to encourage that. So we had actually this evening very much were supported by lots of members of our team. The actual research team were here, the study managers, but also Sam and other colleagues. So I think there's lots of interest and you'll hear what she has to say. But we're really trying to grow the younger clinician and the younger scientist community. It's, of course, the most important and most interesting blood cancer area. And so why not that we have younger people coming in?
It's okay with me. Claire, thank you so much. Don't go away, Dr. Alleman. Just stay with us for a second. So where have you come here from?
So I'm training in Manchester and I've moved to London to do some additional research into myeloproliferative neoplasms.
Okay, well, I just want to tell you, and I know the patients there agree, thank you for your interest in our illness. Okay, are you encouraged too? Because you're looking at the science.
I'm definitely encouraged and excited actually, because over the last 10 years, the whole field has dramatically changed. We not only understand the disease more, we have better in treatment, and the best thing is the treatment's getting better, it's getting more specific, and we're looking at it. It's a subject matter that many more clinicians are interested in and scientists. So it's an exciting arena and it's an exciting field to be in.
Okay, thank you so much.
It's a pleasure.
I hope you bring us the cure of tomorrow, okay?
Thank you very much.
All right. Well, I think we've been covering a lot of ground here, and I don't know if there's someone else coming. Oh, we have one other guest coming. I just want you to know it's been very encouraging to hear this. Also, I think what people tell you, and I have not been around a British crowd, with the condition that I have, and to meet other people who are living with these conditions, living well. Certainly there have been issues that people have faced. Side effects of fatigue is the big one you heard about tonight. Also itching for some people, and also other issues that come up. But overall, we're learning how to control these better. So I think we've got, Esther, is there anyone else coming? Oh, I think we may have one more coming. So I'll tell you what, we'll take a quick break. We may have one more interview for you, and then we'll wrap it up here from London. So we'll be right back from London with more. Oh, wait, here we go. Wait, we have one more coming in a second. I'm sort of filling. This is what they do. So come here, Esther. Come on. Some people have met my wife, Esther, who happens to be here tonight as well. So Esther, just one more thing. Esther, you're very devoted to care partners.
Yes.
So you were listening there as you've been listening to this. What does it mean to care partners to hear what's going on?
Oh, incredibly encouraging. The kind of research that's going on and the kind of information that patients are getting from the discussions that are going on now. It's just as important for care partners as it is for patients, I believe, because when it comes down to it, patient is experiencing the illness, the care partners are there to support them. And if we have the same information and we have the same hope, we can bounce that faith off each other.
Well, as I told Esther many times, I think she may be stuck with me for a long time. I hope so. Okay.
I hope so too.
All right, come on in, doctor. And then we're going to wrap it up. I'm Andrew Shore.
Hi, Donald McLaurin. Nice
Hello,
to meet you.
and you're a hematologist?
I'm a consultant hematologist.
Okay,
yes.
you're here in London?
Yes, I work across both Guy's and King's College hospitals.
Okay, so you were actually listening in on what was being saying today. What would you like to underscore for our audience of patients and family members around the world?
I mean, I think a lot of the most exciting research we're looking at is the new developments as regards the therapeutic agents that are coming into the clinical arena, both in the early phase and later stage clinical trials. And I also think very importantly is the epidemiological studies that Professor McMullen has mentioned. And in addition to that, also the degree of translational research that we're doing based upon symptomatology and how we can address the very heterogeneous symptom burden that patients with myeloproliferative neoplasms may have.
Okay, so it sounds like if people can get to a specialist such as you, and I hope they can, it's an individual discussion both about their symptoms and about what targeted therapies, either approved or in trials, might be right for them.
That's correct.
Okay, good. I'm a good student. Thank you so much, and thanks
much.
for all you do. And we have just a couple of, we've got one family come on in before we go, because we want to end with the patient story. Joe, living with ET. Hi, I'm Andrew. Hi.
And her boy, Carl.
And Carl? Hello, so you're a family?
It's my husband.
Your husband? Come on over here. So who's the patient? You're the patient. Yeah. Okay, so I want to start with Carl. Carl, you listened to all this today.
Correct. Yeah.
How does it make you feel with a community coming together and some leading specialists who seem encouraged?
For myself, it's great. It gives me a much deeper understanding. I can be a lot more sympathetic with the side effects and also the causes. It's just better to have a nicer understanding and also see the amount of other people. No, you're not alone.
Mm-hmm. Okay, and how has this event been for you?
I think it's fantastic. I've been to lots of different hospitals, and what I get from this charity I've never got from anywhere else. It's so knowledgeable, and to meet other people living with it is really, it's nice to know that you're not alone. It's nice to know that there's, people out there that are dealing with it as well.
Support community.
Yeah.
Fantastic.
So I think what I get from this, having had the privilege of our team being here with the MPN Voice folks in this event, is really, this should be a model for what's available worldwide, bringing people together, right?
Absolutely.
Yeah, I mean, because there are people who are hearing you now or in other countries, and they can be encouraged by you, but they can encourage you too.
Yeah, totally.
All
Totally.
right.
With my husband, his dad also has it, which being a rare condition is
unusual.
Unusual.
All right, so you have high hopes for the future?
Absolutely.
Okay.
I love life.
Okay, well, enjoy this guy. Thank you so much.
Thank you.
All right, thank you.
very much.
Thank you, sweetie. We're going to wrap it up from London here. We've been going a long time. Thank you wherever you are. If you've been in Australia, it was 4, 5, 6 in the morning. Thank you for building an early morning around it. People have been on from Taiwan or India or Ireland, not so far. But thank you. And from around the UK, very encouraging news. And also an exemplary organization here, MPN Voice. Wonderful people to work with. And I hope wherever you are, as you're touched with an MPN, that you will take hope from this discussion, get the right treatment, and live life to its fullest, which is what you heard from the Louises tonight. On location at the top of Guy's Hospital on kind of a rainy day in London, I'm Andrew Shore for Patient Power and MPN Voice. Remember, knowledge can be the best medicine of all.